안녕하십니까?
Good morning, ladies and gentlemen. Thank you for attending 2024 WHO Cooperation International Forum on Integrating Rehabilitation into Primary Health Care. I'm very honored to serve as your MC today. I'm Kyung-Ah Song from Spinal Cord Injury Rehabilitation Division of the National Rehabilitation Center. Thank you for joining us at the WHO Cooperation International Forum. We'll examine the importance of the theme of integrating rehabilitation into primary health care and discuss the direction of integration proposed by WHO and examples from Korea and abroad, as well as how to provide effective rehabilitation services within the primary health care. The forum will consist of an opening ceremony keynote address, Part 1, Part 2, and expert panel discussion. We are very honored to have many VIP guests. I'll be calling your names, and when your name is called, please stand up and then be recognized. First of all, President Kang Yoon-gyu, the Korea National Rehabilitation Center. We have with us Technical Advisor Pauline Klintz of the WHO Western Pacific Regional Office. We have with us Professor Jang Sun-nam from Chung-Ang University. Professor Ah-Seok Bae of Ewha Women's University. President Nobuhiko Haga, the National Rehabilitation Center for Persons with Disability Japan. Kim Buckley, the Senior Lecturers Co-Head of WHOCC. On Young Kim, the Director, Department of the Spinal Cord Injury Rehabilitation. Thank you very much for joining us today. We are also joined by overseas trainees from Thailand, Fiji, and Mongolia who are conducting international training. It is expected that this forum will be a very meaningful place to gather opinions to expand the role of rehabilitation in primary health care in the future. I hope you will stay with us until the very end. The forum is also being broadcast live online through the official YouTube account of the National Rehabilitation Center. Online attendees watching via YouTube, please leave your questions and impressions on the comment box. If your comment is captured and uploaded, then we'll also give you some souvenir. Now, ladies and gentlemen, we will officially begin the opening ceremony of the WHO Cooperation International Forum. First of all, I'd like to welcome President Yoon-gyu Kang of the National Rehabilitation Center of the Ministry of Health and Welfare to deliver opening remarks.
So I'll be speaking in Korean. Good morning, ladies and gentlemen. I am Kang Yoon-gyu, the President of the National Rehabilitation Center. It's a great honor to meet you all. We are very pleased to hold the 7th WHO Cooperation International Forum on integrating rehabilitation into primary health care. First of all, I would like to thank and welcome all of you for joining us with us on site and online. My special thanks goes to Jia Han, the member of the National Assembly who will give us a congratulatory speech, and Professor Yong-il Shin from Busan National University Yangsan Hospital who will be moderating our expert panel session. Also, I would like to thank those who travel far distance to honor us with their presence. Dr. Pauline Klintz, Rehabilitation Advisor of the WHO Regional Office for the Western and Pacific Region. Dr. Nobuhiko Haga, President of National Rehabilitation Center for PWD in Japan. Dr. Kim Buckley, Senior Lecturer at University of Sydney in Australia and co-head of the WHO Collaborating Center. Also, I would like to thank the Dr. Sung-nang Jang, President of the Korean Academy for Primary Healthcare, Professor Ha-Seok Bae from Ewha Women's University Mokdong Hospital, and Professor Soo-kyung-bok from Chungnam National University Hospital. I would like to also thank our online presenters, Dr. Catherine Stead, co-chair of the Primary Healthcare at the World Rehabilitation Alliance, and Dr. Abena Tanner, Rehabilitation Program Consultant at the WHO. Since the National Rehabilitation Center was designated as the country's first WHO collaborating center for rehabilitation in 2017, the WHO Cooperation International Forum on Rehabilitation has provided a valuable space for networking and collaboration, sharing the global disability and rehabilitation agenda in Korea and the Western Pacific region. Rehabilitation plays a pivotal role for people's health and quality of life, and it is growing in demand. Through this forum, we will explore ways to integrate and strengthen rehabilitation into primary health care as a way to promote health equity. I hope that this forum will provide an opportunity to discuss ways to promote effective rehabilitation services, including improved access to services and interprofessional collaboration. I hope that the Republic of Korea, World Health Organization, and member states in Western Pacific region establish the agile cooperation and collaboration through this WHO Cooperation International Forum, which brought together global healthcare and rehabilitation specialists. Once again, I would like to extend my sincere gratitude to all the national and international guests, speakers, and organizers for taking time out of their busy schedule to attend this event. Also, I would like to thank everyone who worked hard to put together this great event. Thank you very much. So please remain with us till the very end of the event, and I sincerely hope that this forum will be informative to all of you. Thank you very much.
Thank you, President Yoon Kang of Korea National Rehabilitation Center, for valuable opening remarks. Next, congratulatory remarks will now be delivered by Member of the National Assembly of Honorable Han Ji-ah. Han Ji-ah has served in various positions of the WHO. Due to unavoidable appointment, she couldn't join us but has given us video congratulatory message. Hello, I am Jia Han, member of the National Assembly. My warmest congratulations on the opening of the WHO Cooperation International Forum on integrating rehabilitation into primary health care. I'd like to extend my gratitude to Dr. Yoon Kang, the president of the National Rehabilitation Center, and all those involved in organizing this event. I also would like to extend my sincere thanks to the speakers and the moderator. As one and the only rehabilitation control tower in Korea, the National Rehabilitation Center has been leading the future of rehabilitation for the people in the Republic of Korea. Moreover, NRC has set the ground for global cooperation network in rehabilitation as WHO Collaboration Center. I'd like to pay tributes for that. Especially the theme of this forum, integrating rehabilitation into primary health care, is a paramount agenda that can enhance the people's health equity through universal health coverage. I hope that this forum will be a meaningful opportunity. Especially, I hope we can hear about WHO's global strategy for rehabilitation and the current status in Korea. As a specialist in rehabilitation medicine and a member of the National Assembly and National Assembly Committee on Health and Welfare, I'll do my utmost effort to improve people's health equity and quality of life, taking advantage of WHO Cooperation International Forum. I hope that this forum will stimulate discussions on expanding the role of rehabilitation in primary health care. Thank you. Thank you very much, Member of the National Assembly Jia Han. Once again, thank you very much for giving us a great opening remarks and congratulatory remarks. Before we get started with the keynote speech, let's rearrange our 2024 WHO Cooperation International Forum's keynote address will now begin. Professor Suk-rang Chang, Dean of College of Red Cross and Red Crescent Nursing at Chung-Ang University and President of Korean Primary Healthcare Association, will deliver the keynote address on integration of primary healthcare and rehabilitation service. Professor Chang completed her undergraduate studies at Seoul National University, received her master's and doctoral degree in health science from same university, postdoc fellow at Harvard School of Public Health in the U.S. Her research focus is on primary healthcare, gerontology, and health inequality, and conducted several research projects, including the establishing community center rehabilitation center. Please welcome her.
Thank you very much for a kind introduction. It is indeed a great pleasure and honor to deliver this keynote speech at the WHO Cooperation International Forum. I have some connection with the WHO that I worked as a Asia Pacific Observatory member for the WHO Southeast Asia region, and also I am currently involved in the WHO Long-Term Care Global Network. Can anyone help me put up the slide? So let me continue while we address this technical issue. I am also connected to the photo from the WHO website under the Health Topics section. I played a role in creating a public home visit health management service for vulnerable population, such as elderly individuals living alone or low-income individuals with severe disabilities. So in collaboration with local and central government, I was involved in the project. And so the photo, I actually wanted to show you the photo, but somehow the technology doesn't really allow me. But the photo shows a scene from the home visit nursing services that I have planned, called Neighborhood Community Center on Wheels. Today, I'll be talking about health inequality for people with disabilities in Korea, and also efforts to integrate rehabilitation in primary care. And finally, you see the photo. So this is the photo that I talked about. So if you go to the health topics section of the WHO website, you will see this photo. Of course, the woman in the picture is not me. So it's a nurse that participated in the project that I helped plan. So as I said earlier, I will be talking about how we can transform the healthcare system from the perspective of feasibility. And also I'd like to introduce to you some of Korea's efforts to expand rehabilitation for people with disabilities to the community. One of the key indicators of the differences in health management and risk between people with disabilities and those without is obesity. According to the 10-year trend analysis of data from the National Health Insurance Corporation's health screenings, obesity rates have been increasing across the board over the last decade. However, with the gap between people with and without disabilities is growing. So on the left-hand side, you can see the obesity rate over BMI over 24, and especially among female with disabilities and without disabilities, you can see that the gap is more pronounced than other people in different age brackets. And also in the right-hand side, you can see the rate of the severe obesity, BMI over 30, and you see that the disparity between those with and without disabilities is growing, especially among women. In South Korea, adults aged 20 and older are eligible for health checkups, including cancer screenings, every 2 years, which is supported by the National Health Insurance System. And therefore, the screening rate as for the access to the screening has improved a lot. However, over the past decade, the screening rates between people with and without disabilities have shown a noticeable difference. On the right-hand side of the graph, the red line represents the screening rate for people with severe disabilities. And unlike those with mild disabilities, whose rates are similar to non-disabled individuals, the gap widens significantly for those with severe disabilities. This disparity in health screening rates stems from various issues, including limited healthcare access and the lack of disability-friendly facilities and screening procedures. And consequently, this gap impacts the early detection of chronic disease, timely access to treatment, and ultimately survival rates. Let's now take a look at the stroke incidence rates for people with and without disabilities calculated per 100,000 population by age group. The orange line here represents the stroke incidence for individuals with severe disabilities. So let's just focus on orange lines first. In the first graph, you can see the stroke incidence rates for those in their 50s with severe disabilities. And if you look at the orange line, you can see that it rises sharply in comparison to the second and third graphs, where the rate increases by at least 2 significant steps. And what's more interesting is that the likelihood of someone with a severe disability in their 50s having a stroke is higher than the stroke incidence for non-disabled individuals in their 70s. So that means that the people with disabilities experience aging earlier than those without disabilities, and they have to be prepared for chronic diseases and also geriatric diseases earlier than people with disabilities. So the Korea, in order to guarantee health equity and health access for people with disabilities, we implemented a new law in 2018, and so it talks about the rights for the access to medical services. And the basic philosophy is that the persons with disabilities have the right to receive optimal health care and protection, and they should not be discriminated. And also the law stipulates the need to establish a comprehensive plan for the health and healthcare of the disabled every 5 years, and the details of health management projects and how we guarantee access to medical services for people with disabilities should be maintained. And so based on this new law, you can see that there have been various efforts going on to improve the delivery system that operates holistically by focusing on healthcare, and social services within the community, and the creation of the Regional Disability Health Center serving as hubs within this integrated system is truly a significant achievement. And in the afternoon session, we'll be talking about the examples of the regional disability health centers. It really provides a foundation for local governments to take responsibility for disability health management and to link various welfare resources within the community. However, building the system is akin to laying the water pipes, so it's just beginning. Just as well-installed pipes are essential for delivering water, more effort is needed to ensure that the services that people with disabilities need and desire are effectively delivered through this system. So since we already established the structure, what's important is to ensure that we ensure a clean water for everyone. According to the latest OECD health statistics, Korea has the highest number of hospital beds per 1,000 people, as well as the highest frequency of doctor visit, and hospital stays per capita is also the highest. This situation arises because Korea lacks a primary care system that provides gatekeeping functions, such as first contact and comprehensive health management. So this is due to the Korea's lack of primary care system. To address primary care for people with disabilities, Korea launched a pilot project for the Disability Health Doctor Program, which is really a significant achievement. In other words, the government prioritized the PWD for providing the health doctor. After conducting a comprehensive evaluation, this program offers education and counseling, as well as patient management up to 12 times per year and up to 18 home visits by doctors and nurses. So this program aims to address the unmet healthcare needs and improve accessibility for people with disabilities. However, the program is still in the pilot phase with very limited participation from primary care providers, and awareness of the program among PWD remains relatively low. So still we have a long way to go. And as mentioned by the president of the National Rehabilitation Center, I believe in the future what's important is to establish a multidisciplinary team. And so this is where we have to focus on for the future. And then this is a study investigating the intention of use disability health doctor service, and it was found that elderlies with disabilities showed a particularly high willingness to utilize the service. Additionally, the intention to use the service was even higher among those who lacked caregiving services, such as individuals living alone or without a spouse. More notably, as you can see in the figure on the right, individuals with unmet medical services needs was more than 3 times as likely to express an intention to use the services compared to those without such needs. For individuals with physical disabilities, the intention to use the service was over 4 times higher than for those with other types of disabilities. It is essential to provide personalized healthcare services that consider individual needs and circumstances of people with disabilities. To achieve this, primary healthcare providers must recognize the diverse health challenges faced by people with disabilities and adopt an integrated approach to address them. That's why the NRC is now working hard to come up with the relevant vision, and I believe the role of NRC is truly important. Currently, the rehab services in Korea is provided mainly within the medical institutions, and therefore more efforts are needed to integrate that into local communities. And as a part of such efforts, we try to expand the home rehabilitation services to patients who are discharged. However, such efforts are limited only to those who are discharged from the 50 designated rehabilitation centers, and therefore we have to have a stronger momentum for fast adoption. And through the home visit rehabilitation in post-acute rehabilitation hospitals, patients discharged from the intensive acute rehabilitation services can receive 90-day home rehabilitation services. And in addition, we now see some efforts going on to expand the rehabilitation services for the pediatric patients with severe disabilities at home. And currently, Korea is promoting integrated community care to enable individuals to live healthily until the end of their lives within the community. And a new law has been set out. So across the nation, the various pilot projects will be underway. So now is the time for us to think about what targets and goals we should have in order to ensure community-based integrated care for people with disabilities. Financial resources should be supported, and also in the service delivery system, the role of the public and government should be clearly set out. And also the leadership and the roles of the central and local government should be clearly defined. And also, we have to establish a system to train various types of experts who will be needed for the integrated rehab care for people with disabilities. ICT technology is also a very important part. Through my presentation today, I have been talked about Korea's efforts to have comprehensive approach for local community cares, and also how we can combine the primary care into community and rehab services, and also how we can enhance health equality. But before that, I think Korea should consider in advance the size of the population with disabilities or the size of the policy recipients. Globally, people with disabilities is estimated to be around 15% of the total population, based on the WHO Global Report on Health Equity for People with Disabilities. However, when it comes to Korea, only 2.6 million people are registered as the people with disabilities, much smaller than the estimated population of 7.5 million. So only 5% of the total population, and among them, only 17,000 receive the disability-related services, and also more than half of the registered PWD is elderly, and that proportion is growing every year. And therefore, what's important right now is to focus on what kind of needs or demands that the people with disabilities do have, rather than focusing on government perspectives and administration-centered policies. As you could see from the obesity rate and stroke incident rate, in order to address the health inequality against the people with disabilities, efforts to increase accessibility and enhancing universal health coverage is most important. As for the access, this is to address the lack of policies and also laws, as well as the various discriminations in terms of the communication, physical, economic, and geographical barriers, as well as the lack of understanding in disabilities. And also, as for the universal health coverage, as you can see, various aspects should be considered, including the disability type, health conditions, and also the life cycles. And regardless of where the people with disabilities belong to this matrix, there must be a suitable health guarantee to be provided. Currently, our research team is now focusing on how we can apply smart technologies for a more efficient integrated care program, especially for rural areas where young population live and only the elderly remain with severe population shrinkage. I believe this kind of geographic disparity will only get worse, and in order to ensure integrated care, we have to go beyond providing smart devices to the vulnerable population. Rather, we have to make sure that we could have a multi-layered, onion-like support model with the smart technology, where we can connect the all different health and welfare resources together. And by doing so, I believe we can effectively address the disparity issues for the rural areas. And with that, thank you very much.
네, 장숙란 교수님께서
Thank you very much. Professor Chang Sung-ran talked about integrating rehabilitation into primary health care, advancing health equity. Thank you. Thank you once again. Please give a warm round of applause once again. Let's have a Q&A session. Any questions to Professor Jang Sung-ran? If you have, please raise your hand.
네, 계시면 손을 들어.
So if you have questions, please raise your hand and we'll give you the microphone. If not, then let us move on to the next session.
가겠습니다.
Well, those of you joining us via online, please leave your message or questions if you have any on the chatting box. Now we will begin the first session. First session,
Priorities and way.
Technical Advisor Pauline Clients and Professor Pei Ha-seok, President Nobuhiko Haga, total of 3 speakers will make a presentation. The first presentation is about rehabilitation in primary care strategic priorities and way forward, which is the theme of the first session as well. Dr. Pauline is a technical advisor in the rehabilitation program at WHO headquarters and currently supports WHO regional office for the Western Pacific in the area of the rehabilitation, has worked for 8 years at WHO headquarters, supported several initiatives, and regional advisor for disability and rehabilitation at WHO regional office for 4 years. She holds PhD degree in health system, has over 30 years of experience working in the field of rehabilitation and disability in high and middle income countries, including research, teaching, program management, and technical advisory and practitioner. Please welcome her.
Good morning, everyone, and thank you for the introduction, and it is an honour to be here. I appreciate the National Rehabilitation Centre here in Korea as a WHO collaborating centre. I appreciate its efforts to support rehabilitation in Korea, but also to support WHO and the work we do in the region. And I'm delighted that this international forum is focused on primary healthcare today, a very important topic for WHO and I hope for countries around our region. I'm going to start by talking about primary healthcare and making sure that as rehab stakeholders, and I know that there are a combination of primary healthcare and rehab stakeholders in the room, but certainly as rehab stakeholders, we need to be really well informed about primary healthcare as we seek to integrate and become an increasing part of it. And primary healthcare has had a long journey. The famous Alma Ata Declaration for strengthening primary healthcare was back in 1978. Alma Ata is a location in Kazakhstan. And so 46 years ago, there were international organisations strongly endorsing, advocating for strong primary healthcare. 40 years later, there was the Astana Declaration. Astana is also a place in Kazakhstan. And this figure that you can see is from the publications, WHO publications at that time. And it really seeks to explain how while primary healthcare is very much about what's in the yellow part of that circle, the primary care services and the essential public health functions as a core component of integrated health service, it is also very much about the multi-sectoral policy and action and empowered people and communities. So primary healthcare is very much a strategy to really strengthen, bring a central focus to primary healthcare services in countries. And for countries like Korea that often, as Professor Yang mentioned, often have developed probably with more of a tertiary secondary focus and specialised medical focus, it's actually quite a significant shift and message to countries like Korea that actually the more efficient, inclusive, equitable ways to really provide healthcare is through these strong primary healthcare and with essential public health functions as the core to integrated service delivery in countries. Alongside these documents from 2018 is this primary healthcare operational framework. And I put it up because it's important, again, that we just understand the basics, that on your left is, of course, the three components that I just mentioned, the essential services, the empowered communities, multi-sectoral action. In the middle is the entry points, and these entry points are relevant to us as rehab stakeholders, but you can see that some of the topics, even like Kim that will be speaking later today, digital technologies and those opportunities that exist in strengthening primary care and in strengthening rehab in primary care are relevant. And why I put this up is also that we really understand that primary healthcare, as you can see in this results column, is really about increasing the access, the utilisation and quality, but it can really contribute to that overall improved participation, care seeking, health literacy, and then even impact on determinants of health. And ultimately, if we want to achieve universal health coverage, if we want to achieve greater equity, investments in primary healthcare are actually the way forward. And governments around the world, ministries of health around the world are really recognising that it's primary healthcare that they need to focus on to achieve universal health coverage, but to achieve that with good equity. So, of course, I assume most of you feel familiar with primary care, but I will just remind you that in all the documentations and statements and ways forward, it is about health promotion, prevention, treatment, rehabilitative and palliative care. All these are considered part of primary care. As mentioned, it's really about achieving more inclusive, equitable, cost-effective healthcare. Primary care is, of course, where we generally promote that first contact into healthcare. It is one of the words we have there in red is comprehensiveness. And I want to just for a minute explain, because a lot of people have the perception that primary healthcare is quite narrow or quite basic. But in fact, the trend and the great movement of primary healthcare is that it is a wide scope of care. It is comprehensive. And so this is really the direction primary healthcare takes. More and more services are part of it. It obviously is about the continuity, the coordination, and a feature of primary healthcare is that very community local focus. It is often supported by local governance measures and local decision making that really bring about a responsiveness to the local needs. Primary healthcare is where the diagnosis of most health conditions can occur. Obviously, the identifications in problems of functioning, very relevant for us, and of course, referral. It's quite amazing to see that bottom figure there, that 80% of health needs, and that is, I have no doubt that is quite accurate, that 80% of health needs can be met in primary care. That is the estimation by WHO. And I think I just want to prompt you all as rehab stakeholders that if you think about rehab and you really understand what we do and the breadth of what we do, you know, well over 50% of what we can do could be in primary health care, and if not more, and closer to similar sort of levels. So it is really a challenge for us, I think, in rehab to recognise and see just this enormous opportunity and potential to be such an integral component of primary care. I put up that, it's actually not in the printed PowerPoint, but that resource, that front cover of that WHO resource, a primer there. If any of you want to read and really understand primary healthcare and this agenda increasingly, that resource is particularly a good one, and it's just from 2024, so a new one. So while I can talk about primary healthcare, and we all know, and certainly WHO as an organisation recognises its enormous potential, and we in rehab were mentioned in that Alma Ata Declaration back in 1978, and yet we have, after many decades, this situation where rehab is developed often at the least at that primary care community level. And, you know, I will acknowledge that it's understandable in some ways as services develop in emerging, particularly as health systems are immature and emerging. It's understandable that we often do start services in tertiary and secondary levels of healthcare. And that's certainly the case globally around the world. And we've done surveys and we've done lots of national situation assessments. And we know that rehab, we will see our rehab doctors and our physio, occupational therapist, speech language therapist, psychologist, social worker, maybe prosthetist, orthotist, we'll see them generally in the tertiary, secondary level and a lot less in primary care. And yet it is now where we need to jump on this opportunity and really put some focus. And why do we need to be in primary care? So I'm going to, as I talk through this list, I want you to notice maybe just even the way I'm framing this. We need to be in primary care. Why the benefits is that we will meet the population's health needs. There is a lot of need to be met in primary care. And we will actually achieve better health outcomes for primary care services. We will contribute to health outcomes, to those functioning, quality of life, well-being outcomes that primary health care deliver. We will certainly be supporting the person-centred, comprehensive, coordinated, quality elements of primary care. And we can enable much earlier delivery of health interventions to reduce the needs of often more expensive health care. The fifth point there is, of course, that we will increase access to rehabilitation, that we would be closer to where people live and spend time, and we can really meet those underserved population groups, the more rural communities, and where people have, for example, limited mobility or transport options. So we can be closer and we can deliver much better in community settings. Because when I talk about primary care, I'm generally talking about community settings as well. We are talking about primary and community care. They're together. And you may notice that I have intentionally put the first 4 dot points really to say that the reason we should be there, the benefit is that we make primary care better. Rehab stakeholders, and particularly our therapy workforce, our physiotherapists, our occupational therapists, our speech language therapists, or our psychologists, our social workers, being in primary care makes primary care more effective, better. And that's really the fundamental reason. Of course, we increase access to people with rehab needs. And thanks to Professor Yang, of course, we will absolutely meet targeted needs, for example, with the disabled population, with people with disabilities, and make sure that they're accessing services and have that adequate care in their families. But it is really also about us being a part and seeing ourselves as essential to the continuum, the comprehensiveness of primary care. So there's some challenges, and I'm try and keep it a bit simple, but a bit as we move forward. First of all, 3 challenges. We sort of have low demand and low awareness, I would say, from a range of stakeholders about the importance, the benefits, the contribution rehab makes. We often have systems, the health systems, that are not enabling. There's not necessarily the financing arrangements, the policy statements, the information systems that really enable that expansion. And we haven't done enough of that really focused service planning and design. A little bit like the work, though, that is now happening in Korea for people with disabilities, where we really try and design and conceptualise and plan and then implement and learn about how to really develop these services in primary care. So those three challenges, I flipped them into three strategic approaches for the integration of rehab in primary care. One, building that political commitment and awareness. Two, creating the enabling health systems. And three, focusing on that design and implementation and learning around the services and how they're organised and arranged. And I'll just go through these. So first of all, building the awareness. We certainly need to spend time, like I know people will do and say today, understanding the need, and then of course the unmet need. And I do want to remind you all, and I think this audience, and I know in Korea you've heard WHO talk about rehab for a long time, but the rehab needs in the population are of course people with disabilities, but are of course a lot of other people without disabilities. And you have to be very mindful of that as you really promote rehab in primary care. This is about people with musculoskeletal conditions, some chronic cardiovascular, chronic neurological, a whole range of hearing, vision or other impairments that are not enough to classify someone as a person with a disability in a country or meet a certain criteria that countries have for disability. So the bulk of actual primary care needs are the bulk of rehab needs in primary care are often people that are not people with disabilities, just people with illness, injury, chronic health conditions. And we need to really bring that, raise the awareness, bring the data and make that clear. And then highlight what we bring to primary care. We make rehab particularly, and this is where sometimes, countries and how they organise services and the roles of the doctors and the allied health or the therapists can get a little bit political. But I want to remind you that we and particularly therapists, because therapists are not as expensive as doctors in all health systems, and there are cost savings that can be made by getting therapists into primary care, really delivering a lot of the care that's needed at that level and saving on specialised medical care. And there's a very strong cost savings, and there's plenty of evidence out there in the different, particularly in different journals or different, if you look at the professions, physiotherapy or OT, where they make that very clear. So always we need to keep building this awareness about the needs and about what we mean by rehab and how we can benefit. And of course we contribute to the rights and the equity for people with disabilities, but we contribute to health outcomes. We need to be creating this policy space, having these dialogues, and we as rehab stakeholders need to be part of the primary healthcare dialogues. This shouldn't be about rehab stakeholders thinking, how do I bring rehab down to primary healthcare? How do I work to just create rehab services in primary healthcare? No, this is about rehab stakeholders thinking, how do I become part, in unison, completely integrated into primary care? It is primary care that we need to be part of and to be demanding that we are there, not us pushing always down into primary care. We want the primary care people to recognise and realise that enormous benefit and that we bring to the health of the patients that the primary care sector bring or serve. And this is often a political commitment. This is the political element. This is often a political commitment to expanding allied health. And when I say allied health, then countries use different terminology. But allied health, I mean, again, our therapy workforce and generally our therapy workforce. Obviously, allied health can mean other health workers, but the cost savings, the big benefit for governments, the political commitment is to expand allied health in primary care and have them working with family medicine, with primary care. That's where the cost savings and the benefits are. And there's of course a role for medical specialists sometimes and often, but not always. In fact, allied health, when you have a strong allied health sector working closely with just primary care, the family physicians, that's really meets the need of a large amount of the population. In terms of the enabling systems, we want to see rehab reflected much more in those primary healthcare policies, plans, information, decision making. And I'll tell you a little story from Australia. Every decade we develop a primary healthcare policy, a big primary healthcare plan, a 10-year plan. And we have our 2022 to 2032 Australian primary healthcare plan. And obviously those steering committees that drive those primary healthcare plans are really crucial. And for years, those steering committees have been composed of family medicine and sometimes nursing, but even nursing can be quite underrepresented. It's very led by family medicine. And for the first time in the development of the 2022 Australia's primary healthcare policy, out of the 12 members of the steering committee, we had many family medicine doctors, we had some nursing, but we had the Australian Physiotherapy Association and we had the Australian Allied Health Professionals Association. 2 out of the 12 steering committee members were allied health. And that reflects the reality of this transition from primary healthcare must move to this much more inclusive allied health, completely integral to it in order to really make the cost savings and meet the population need. So it's quite telling and even just to share, as a physiotherapist that graduated in Australia a number of years ago now, over 35 years ago, back then the majority of the physiotherapy and therapy workforce was located in tertiary secondary settings. Now in Australia, the majority of the physiotherapy, occupational therapy professions are located in primary care. They're working in primary care. They're working with government-funded primary care, private practice primary care, community rehab teams, community disability service organisations, but the majority of the profession is now at the primary care level. So there is this massive transition that, countries like Korea are potentially at the start of really orientating services much more for rehab care, allied health rehab care to primary care. Of course, we need the financing to do that. We need those, whether it's the benefit packages, I know you have your National Health Insurance Scheme, we have to bring those service packages to enable the practitioners. And of course, there has to be gatekeeping. And, even in Australia, if you're accessing your physiotherapy in primary care, you still generally, if you're getting the Medicare funded, you're getting a referral from the family doctor, family physician. It's not like an open slather, but you have much greater access through that. And of course, we need the financing. And I want to acknowledge that in every country, rehab services are funded by health and generally by some other agencies that are very focused on people with disabilities. And sometimes, of course, there's veterans, for example, other services. But we expect that buckets of money will fund rehab and other services for people with disabilities in primary community settings. But we expect that there is that really funding coming through healthcare to fund rehab in primary care. And most countries will have a combination of a couple of these financing mechanisms that really enable that expansion of rehab in primary care. We need the workforce regulatory mechanisms. We do want, again, the savings and the benefit is bringing allied health into, therapists into primary care with greater access, and ensuring that we have a primary healthcare ready workforce, that therapists can safely deliver care, and effectively deliver care autonomously. That's what we need. That's how we get a more efficient and effective primary care sector. And of course, with assistive products, we want the financing of them and we want that delivery also. So there's a range of enabling mechanisms needed. And finally, just with that third strategy, we really need to roll our sleeves up and really get into that service design and understand that this is about planning and co-design of rehab in primary care. This is really about recognising too that this will vary across countries. We need to tailor this to the population needs, to the resources. We need to build rehab into those service packages, clinical guidelines, referral pathways, and make sure that rehab is very much in the models of care. And models of care is language that gets used a lot in primary care. And there's broadly primary care models, but there will be models of care that emerge. And the example from Professor Young with the care for people with disabilities is a classic sort of model of care that's being worked and, organised around the population of people with disabilities. But models of care will emerge around other generally health conditions or groups of health conditions to really make that. And again, our therapy, allied health, we need to be in those models of care as well as essentially having what you were referring to is almost like a rehab model of care. And we will find, again, in countries, we often end up with community rehab services. They are a model of care, where you can actually do the outreach and do the home visits. But that's not the only model of care for primary care. And recognising that we need to do demonstration projects, work subnational, local levels, and really bring learning and adaptation and evolution and phased approaches to what we do. When designing rehab in primary care services, I'm almost there. This needs to be driven always when we do any health sector, health service planning. The starting point is population needs. It always has to be. And we do need to understand that patient needs. And like I said, there is the disability needs, but there's a lot of other kind of chronic health condition needs. WHO estimates 2.6 billion people live with a health condition. In our snapshot drawing on global burden of disease data, they have a health condition that typically benefits from rehab. The need is large, and it's growing, of course, with chronic disease, ageing populations. And it is acute, subacute. We can't not rule out the acute. Musculoskeletal conditions, classically, you can have acute ones that their needs are met in primary care settings. You don't need to go beyond. So it's acute, subacute, long term. We need to keep thinking about this high levels of integration into the existing primary care services. This is not about us just bringing rehab down in a vertical approach. No, this is about us organising ourselves around the existing primary care and being part of it, and recognising models of care and being in those models of care. This is about us, of course, really considering especially that community delivery and, the financing that enables community delivery, enables outreach. It is always going to be tailored. We can't give you a recipe for this. It is very tailored to your country, your resources, your existing primary care arrangements, but it should always be complementary. It is around multiple professions. This is primarily, and it's sometimes not an easy message to convey, but this is primarily about, because primary care, really this is a lot about bringing your therapists, And we love rehab medicine, and rehab medicine does, rehab medicine doctors do have a role. But the big benefit, the big gain to be made in cost savings, in greater care, is really that focus on your therapists in this level. Starting from acceptable bases and lots of local consultation and development. I won't say that's almost there. All right, so there are resources that we have, and like our WHO package of interventions for rehab, which, for example, is based on health conditions and is used for health financing. Its primary purpose is to help countries when they're defining those health benefit packages. We have resources, for example, around the minimum data that you should be collecting in health facilities. We really promote, of course, technical support, working with countries, and in our low middle income countries, the concept of the demonstration project, where we choose a local government area and we say, look, if we put a therapist here and we have some training of nurses or doctors here, and we strengthen referral pathways, and we, collect this data, and we have some mentoring, it's putting all those pieces together to say, in a demonstration project, this is how it could work, this is scalable for the country, and this is how we can build up. There is a resource which my colleague Abina Tanner, who you will listen to online later today, talk about the basic package of interventions for rehab. So that resource is very specific often to the less resource settings, because it's actually promoting task sharing. What can doctors and nurses, primary care, doctors, nurses, community health workers do to recognise people with rehab needs, to better refer, but to provide basic advice and education. So it supports a task sharing approach. And we are developing another new resource at WHO just to try and bring all this together. The other thing that we are doing is we have our World Rehabilitation Alliance, and you will hear Kate Steed, another recorded speaker, speak this afternoon about that. Lots of products. So ever since 2017, when WHO launched the Rehab 2030 initiative, which I'm sure many of you have heard about for some time, we have been busy producing a range of different products. So these are the products. And the new one that I was talking about for primary care, probably it won't be launched until 2026, but it will, for example, bring that data. When I mentioned the 2.6 billion people with rehab needs, that's based on the global burden of disease data. And we are going through a process of that need, how much of it could be met in primary care, because we actually are pretty sure we can start saying to countries, the majority, by far the majority of your rehab needs could be met through primary community settings. We will talk about those enabling factors, the enabling systems factors, designing and scaling up services. And always we have to bring that embedded learning and doing. My final message, I just want you, thinking predominantly as rehab stakeholders, I want you to recognise that we strengthen rehab. I'm a rehab stakeholder. We strengthen primary care. We make primary care better. We make the existing care that's being provided in primary care better. We will also, of course, meet the needs of people with a lot of rehab needs, but we will strengthen primary care outcomes. And of course, primary care in itself will strengthen rehab, because we need much more flexible, dynamic approaches to rehab. We need to recognise rehab is not just the services under the rehab medicine doctor, it's all those rehab services that are being provided, often with the family physicians, or the therapist working with family physicians, or the therapist working with neurologists, orthopaedic surgeons, other ones. But for primary care, it's the rehab workers working with primary care, with rehab family doctors. That's really what's crucial. So thank you. That's it. And it's a pleasure to be here and share the journey. Thanks.
네, 발표 감사드립니다.
Thank you very much. Once again, Thank you for sharing WHO strategy about how to approach rehabilitation and its integration into primary care. We do have few minutes left. If you have any questions, please raise your hand. If not, let me ask a question to you. Can you hear me? Can you hear me? Can you hear me? Thank you very much for your great presentation today. You've talked about how to integrate rehabilitation into primary care and talk about various approaches and strategies. And it's very comprehensive strategies. And also you pointed out 3 challenges as well. So in applying these strategies in each country, it's quite difficult. So does WHO has a special effort or special ways to apply these strategies to each country?
I think when we really work with governments, and I mentioned how you're right, there's a lot of strategies and there's a lot of difference in countries in regards to existing primary care services. So primary health care, while we all have a certain familiarity with it, there is actually quite a lot of variation across countries, how it's organised, how it's arranged. So hence, we really need to tailor to countries. And in a way, that's why some of what I shared, it's very high level sort of principles, ways forward. Because really, it's what we call the technical support that we do with countries and working with WHO staff, but consultants and other people generally working with governments to design. And that's why the demonstration project, particularly for low middle income countries, can be such a useful way forward, because it really makes it very real. And we sort of really focus a lot on that service design and planning. And we have to support the service design and the planning and the development, and simultaneously at the same time be creating those enabling factors, working with creating the policy dialogue, creating the awareness, making sure our workforce is primary healthcare ready, making sure our financing arrangements and the budget, the benefit packages are being developed. So it is always a technical support, I would say, approach that we use for of course, that's mostly in our low middle income countries. And then we trust and hope that the guidance that we provide is used for other countries. They can use it and bring some of that practice and some of that thinking to their approaches. I hope that answered the question. Yeah, thanks.
Thank you very much for your answer. Well, I guess there are no further questions. And then that concludes the first presentation. Please give a warm round of applause once again to Technical Advisor Pauline Kleinitz. We will introduce the second speaker.
So the Professor Bae Ha-seok from the Department of Rehabilitation Medicine at Ewha University Mokdong Hospital will give us the presentation. Professor Bae earned his bachelor's and master's degree from the Yonsei University and PhD from Korea University College of Medicine. He currently serves as the chairman of the Strategic Planning Committee of the Korean Academy of Rehabilitation Medicine, president of the Korean Society of the Limdoma, and also vice president of the Korean Society of Sports Medicine. He has also been a member of several policy-related committees for the Ministry of Health and Welfare. So please give him a big hand.
죄송합니다. 잠깐.
Sorry for a technical problem.
그 화면 나오는 동안에 말씀드리도록 하겠습니다.
So let me begin my presentation while we address the technical glitch. Today, what I'm going to talk about is the Korea's unmet needs for rehabilitation services. So based on the various literature and also the publications so far, I will give you some Korea's landscape for the rehab services. So I'll begin my presentation with the literature review, and then I will explain about Korea's situation. Currently, I am serving as the chair of strategic planning for the Korean Academy of Rehabilitation Medicine. And basically, I'm in charge of policies and future policies. That's why I think I'm invited to this auspicious occasion. Thank you very much for your invitation. So this is the content of my presentation. So let me begin with the unmet rehabilitation needs. I reviewed the several literature, and I found that many studies define the situation where rehabilitation care is needed but not adequately provided as unmet rehabilitation care needs. According to research by Kamenov and colleagues, the reason for unmet rehabilitation care include a lack of services, regional disparities, cost issues, and accessibility challenges. So all of these factors work together to have unmet needs, and Foster and Sinner research supports this by highlighting that these unmet needs persist after discharge, often leading to continued functional impairments, pain, and also psychological issues. The rehabilitation care delivery system, as you can see, so as you know, the paralysis, stroke, and also the brain injury, spinal cord injury, and also the myocardial infarctions, these kind of disorders occur mainly in the tertiary center. And then after the recovery phase, the patients move to community. However, as you know, the rehabilitation care delivery system, it works in reverse compared to traditional healthcare delivery models. So we really have to have an in-depth understanding. But right now, the current system suffers from a lack of understanding and incomplete implementation, leading to various unmet rehabilitation care needs. So this is the problems that Korea suffer. And also, if you look at the several literatures, you can see that rehabilitation services are needed for a variety of health conditions, including non-communicable disease, neurological disorders, and trauma. However, in many countries, the availability of rehabilitation services falls short of the demand. The main reason for this shortage includes the lack of transportation, geographic imbalance, and insufficient rehabilitation personnel and facilities. According to a WHO report, 92% of diseases globally require rehab services. The report emphasizes that strengthening rehab services require policy approaches tailored to specific needs of each country. And in Korea in particular, there has been a growing demand for policy support to ensure timely provision of appropriate rehabilitation services. And as a result, since 2017, the government has implemented the designation of rehabilitation medical institutions for the acute and subacute patient, and we have also launched the pilot project for a special payment reimbursement system. This is the literature review study on the unmet needs of stroke patients in the community. The study found that the highest unmet needs were related to the provision of information, lack of rehab services, and the management of cognitive and memory impairment. The second most common unmet need in rehab care was for rehab services, with the main issues being fatigue, muscle spasms, and similar concerns. And the third most unmet need was for mental health services, especially managing cognitive issues, mood disorders, and stress. And also some stroke survivors, they experience a significant decline in their quality of life because their needs are not fully met. And with the lack of information support and rehab services, they see that these are the main reasons behind their poor quality of life. Although information is provided in hospitals, but it is often too complex and difficult to understand for patients. Therefore, patients and caregivers, they often do not have a clear understanding of their conditions. And as a result, they are not really clear what kind of rehab services they have to get in the community. And with these situations, when patients return to community, they often feel that they are abandoned by the hospital after discharge. So they experience the sense of frustration and abandonment, and this is where we have to develop more diverse kinds of rehab services. In the case of the UK, rehab needs are assessed. UK is actually an excellent example for effective rehab services. So they utilize the Rehabilitation Complexity Scale, or RCS, to assess rehab needs, which categorizes patients into 4 groups, A, B, C, and D. Patients in group A and B, they are classified for inpatient treatment, and also based on a very detailed evaluation criteria. Again, the patients in Group A are divided for different kinds of services based on the severity of their disabilities. And also those in Group C and D, they receive outpatient community care, ensuring that rehabilitation services are tailored to the severity of the patient's conditions. So here you can see the hospital inpatient track and outpatient track, and experts are all involved. So from the acute to subacute to chronic phases, it is very clear what kind of medical services the patients have to receive, and also in community at home, what kind of services they can enjoy. So these are all clearly set out in the patient management system, so that patients will not be left behind even when after they're discharged. And this is the case of Australia, that of course this local government do have different policies, and therefore things are pretty various. But patients are often classified according to their rehab needs from level 1 to level 6. So level 6 refers to the high severity with the highest rehabilitation needs. So they are referred to tertiary hospitals to receive sophisticated rehab services, whereas the patients at level 3 to 5, they're connected to rehab institutions. So you can see that based on the patient's needs and the severity of their rehab disabilities, patients can enjoy different levels of the services that are suitable for their conditions. So in this regard, I believe Korea has a long way to go. While these kind of categorization and tried systems are now under study in Korea, but we really have to facilitate. Now let's talk about some unmet rehab needs in Korea. In Korea, there are various types of rehab facilities, including tertiary hospitals for acute and rehab hospitals for subacute care, and also the long-term care hospitals for chronic conditions. However, there is a structural issue that prevents the provision of specialized rehab services tailored to different stages of recovery, because patients are not accurately assessed and therefore they are not effectively tried. In other words, in the UK, for the patients in Category A, they can receive the home visit services, and Category C, the patients enjoy inpatient cares. However, these kind of systems are not really clearly set out in Korea. And also, the payment for the rehab service is very low. That's why there is a tendency among tertiary hospitals that they are reluctant to admit rehabilitation patients. In order to address these issues, the government has implemented various programs, but still we have a long way to go. But still, we have some good news that for the rehabilitation hospitals for the subacute patients, the government recently implemented a pilot program to designate rehabilitation medical institutions and conduct pilot projects for adjusting payment rate. So here you can see acute and subacute and chronic phases. So we have different kinds of services based on these three categories. And so from the year 2020, a more customized rehabilitation payment system was introduced as a part of the efforts to reform the low payment rate for rehab services. And we have 5 different kinds of the disease groups. So the Group A for brain injury, Group B for spinal cord injury, Group C for hip replacement, Group D for amputation, Group E for immobilization syndrome. So we categorize patients based on these 5 groups, and we have conducted the pilot project. And as a result of the pilot project, there has been a gradual increase in the rate of patients returning home from 2020 to 2023, with an average home return rate of approximately 55%, still very low compared to other countries, which have average home return rate of around 70%. And as for the low payment, we have created a bundle payment system per unit, allowing patients to receive rehabilitation services as needed, even the services which was not accessible under the previous system. And with the introduction of this customized rehabilitation payment system, the patient satisfaction have improved, and also they now enjoy more diverse kinds of services. But compared to the previous model, especially for the cerebral disease patients or patients with brain injuries, occupational therapy sessions for these patients increased significantly, while the number of physical therapy sessions has shown some decrease. Anyway, providing the adequate rehab services that the people with disabilities need is critical in making improvement. And also from 2017, so we implemented this pilot project. And through this project, there has been an overall increase in the number of rehabilitation medical professionals. Not only doctors, but also the nurses, the occupational therapists, and physical therapists. So if you compare the data before and after the project, it is evident that rehabilitation specialists have all grown in number. However, still there are many limitations. So although we have made some improvement, but still, and we classify the patient into 4 categories: acute, subacute, chronic, and subchronic. And these phases are not well connected to ensure a smooth, integrated rehabilitation models. So right now, what we focus on is how we can make a smooth transition from acute to subacute and also the chronic phases. Especially when we send patients to community, so there was an idea to create some new payment system, so we created that. But because of some limitations, So we created a fees for the community linkage and integrated rehabilitation home visit, but this is only 0.05%, which means that the very few medical institutions actually claim for this reimbursement. And this indicates that although we came up with some system and measures, they are not utilized actively. And so we really have to address this issue. The second problem that we have is that the concentration of the rehabilitation medical institution, which is very notable. So most of the rehab medical institutions are located in the metropolitan area. So for the subacute rehab medical institution, they're all located in Seoul and Gyeonggi areas. And therefore, the people living outside these areas, although they want to receive rehab services, because of the geographic disparities, they cannot really enjoy strong access to rehab services. So this is something that we have to address, and we have worked hard in cooperation with the local governments, but still there are many practical issues that we have to address. And if you look at the home visit rehabilitation services, again, you can see that only the Gyeonggi area has shown a significant increase because the area has a very high population and great accessibility. And therefore, only the Gyeonggi area has shown a significant increase in activation of these services. So I believe we really have to expand on this to other communities and cities. And this is the research from Professor Kim Tae-hul. And in order to look at the regional disparity, so we looked at the data and we calculated the supply and demand ratio. And you can see that the supply and demand ratio of 0 indicates that there are no rehabilitation beds available any longer in large cities. And it has been reported that 158 out of 229 districts lack rehabilitation beds. So again, we have to find a solution to address this kind of issue. And also, although the supply-demand rate is not 0, still there are 72 with the supply-demand ratio of 1. So this clearly shows that the rehabilitation care environment is still primarily focused on the metropolitan area and major cities. And within the Gyeonggi region, you can see that there are about 45% of the regions. Again, these localities show the 0 supply-demand ratio. So this means that, again, there is a serious shortage of rehab medical institutions. And also, as for the HCPs, including doctors, occupational therapists, and also the physical therapists, it has been found that approximately 30% of the 229 districts lack rehabilitation medical specialists and occupational therapists, highlighting a very severe imbalance in the distribution of healthcare personnel across regions. So you see that the most of the rehab specialists, they are concentrated in the large cities. And occupational therapists, I understand the number of them is 1/4 of the physical therapists, and there are many areas that do not have access to services by occupational therapists. So about 66 districts do not have the occupational therapist, and 9 districts do not have physical therapists out of 229. And by diseases, you can see that for the musculoskeletal rehabilitations, again, it has a very low implementation rate and service provision rate. And for the cancer and also the rare disease and cardiovascular diseases, again, rehab needs is very significant in these diseases. But because of the geographic issues and also the lack of HCPs, although there is a demand, but their needs are not effectively met. And in evaluating medical institution, one of the most useful indicator is the discharge rate from rehab hospitals to community. And for the Gyeonggi area, the discharge rate from rehab hospital is 40%, which is significantly higher compared to other regions. Because Daejeon and Yeongnam, you see that that figure is only like 11%. In other words, most of the patients, they discharge directly from the tertiary hospitals rather than going through the rehabilitation medical institutions. They should be able to regain their independence after receiving rehab services in rehab hospitals, but because there is a severe shortage of the rehab medical institutions in local areas, and therefore their needs are not properly met. Now let's take a look at the infrastructure. So even if they move to the communities, discharged to communities, again, there are very few organizations that provide rehab services. So one of the best way to address this is to promote the home visit rehab services. That's why the Korean government recently launched a pilot project for this, and various studies and investigations have been underway in order to understand the efficacy of this project. And overall, there have been a very high demand among PWD regarding the home visit rehab services. But still, we have a lot of technical and also the administrative barriers. So how we promote home visit rehab service, I think this is very important. And among patients who underwent the rehabilitation therapy after total knee replacement surgery, 41.3% reported that self-rehabilitation was very difficult. The primary reason cited for that difficulty in self-rehabilitation was the lack of someone who can assist with rehabilitation exercises, which accounted for 85% of the responses. And about 90% of the patients expressed, therefore, a preference for inpatient rehabilitation therapy and indicated desire for readmission. So this highlights the challenges that patients face in rehabilitation and underscores the demand for inpatient treatment. Once the patients go back to community, then they should be aware of what kind of rehab services they can have access to. But there is currently a lack of system connecting healthcare institutions with the community. There are several key organizations related to rehab services after recovery phase, including the Community Center for Disabled People and also the Public Health Center and so on. However, they are not well coordinated, and it creates a confusion among people with disabilities. And they are not really clear where they should go to receive what services. So we have to have some control tower, and so we have public health service centers, and they offer rehab services, but this is for both the people with and without disabilities. But we have the regional disability health centers, and they focus more on the people with disabilities exclusively. So we have to have these kind of centers to be created more. In 2017, since the implementation of the Act on Health Rights and Access to Medical Care for People with Disabilities, or Health Rights Act for PWD, the government has established and designated the regional rehab hospitals, regional medical institutions, and regional disparity health centers and community health and rehab centers for PWD. However, a significant issue is that all these institutions have very similar purposes and overlapping content. And therefore, I think things should be streamed. And also, in the case of the acute care discharge support program, there are administrative burdens involved. In other words, they have to provide too many EMR records for each patient, and sometimes small hospital they have to hire a personnel only for transferring the documents for patients for rehab services. So again, this is something that we have to address in order to expand the programs so that more hospitals will take part in. In order to address unmet rehab needs, continuous rehabilitation is essential and policy support is critical. So although we do have the system that tries the patient based on acute, subacute, and chronic phases, but still we lack the infrastructure for patients to receive rehabilitation after recovery phase. That's why home-based rehab could be a viable solution, and Japan has been ahead of South Korea in adopting home-based rehab services. So in Japan, the number of facilities claiming for home-based rehab services increased significantly in 2007, and the number of patients receiving the services grew from 40,200 to 136,000. So it really showed a significant upward trend. So after 6 months of the pilot program, they actually conducted the functional assessment and found that the ADL and IADL improved a lot after the home-based rehab activity. So this indicates the importance of home-based rehab service. So we really have to benchmark Japan, and when applying what we learned from the Japanese cases to Korea, of course, we cannot copy and paste the Japanese system because we have different reimbursement systems and also healthcare landscape. So we really have to develop a way that could be tailored to Korea's needs. And what's most important, I believe, is to build a so-called control tower. So maybe we could utilize the regional disparity health center as a control tower to connect all these different health and rehab resources and infrastructure so that we can provide a more integrated care to patients. So this is conclusion. The most critical issue regarding unmet rehab needs in the country is the establishment of rehab service delivery system and addressing the regional imbalances in recovery phase rehab hospitals. This requires an active evidence-based strategic approach from the government. And also we have to develop a criteria to assess the Korea's situation, and I think this is something that the Korean government should focus on. And this is the reference that I referred to in coming up with this presentation. So I only talked about some basic problems and situation. The Korean government worked a lot to improve rehab services, but still it has a long way to go. That's why we need partnership and cooperation. When it comes to rehabilitation, it really requires a very strong expertise from all different kinds of disciplines. So multidisciplinary cooperation with extensive expertise is critical, and we cannot really achieve that from the community setting only. Therefore, the government policy support and also the efforts from the community should be combined. Currently, we are having this WHO forum. I'd like to use this opportunity to ask for more support from the WHO. And with that, thank you very much.
네, 발표 감사드립니다.
Thank you very much once again. He talked about unmet needs for rehabilitation service in primary care. Are there any questions to Professor Pae?
네, 그러면 시간 관계상 다음 발표로
Due to the limited time, we'll go to the next presentation. Please give a warm round of applause to Professor Bae Ha-seok once again. Now, the final presentation of the session 1, we are going to turn to Dr. Nobuhiko Haga, the president of National Rehabilitation Center for Persons with Disabilities, Japan. The presentation title is Evolution for Integration Rehabilitation Services. He's currently in charge of the entire center, including Research Institute, Hospitals, Rehabilitation Service, and University. He graduated from University of Tokyo, Graduate School of Medicine 1987, worked as orthopedic surgeons for 19 years, specializing in pediatric orthopedics and childhood disabilities. He was appointed as a professor and chair of the Department of the Rehabilitation Medicine at the University of Tokyo in 2006, served as a director, and has published more than 160 papers. Please welcome the president.
Good morning, everyone. My name is Nobuhiko Haga, the president of the National Rehabilitation Center, Japan. I am deeply grateful to the president, Professor Yeon-kyo Kan, and the organizing committee for giving me this occasion of talking. My title is Evolution for Integration of Rehabilitation Services in Primary Care in Japan. I have no conflict of interest to disclose in connection with this presentation. As Pauline Kleinitz stated in her speech, Declaration of Alma-Ata from the International Conference on Primary Health Care, September 1978, stated that primary health care addresses the main health problems in the community, providing promotive, preventive, curative, and rehabilitative services accordingly. In the same year, U.S. Institute of Medicine released a manpower policy for primary health care report of a study, and the following words were described. The 5 attributes to the practice of good primary care are accessibility, comprehensiveness, coordination, continuity, and accountability. As for this word comprehensiveness, Japan Primary Care Association explains in its homepage that comprehensiveness means dealing with all complaints and problems. It also states that intervention to lead a better life, including rehabilitation, to cope with diseases and disabilities is an important viewpoint. Before starting to explain about integration of rehabilitation services in primary care, I want to review the brief history of rehabilitation in Japan. Around 1900, nurses, masseurs, and other unlicensed persons were engaged in physical therapy and functional training. By the end of World War II in 1945, physical training and prosthetics, orthotics rapidly developed. The photos in the upper right shows the patient with incomplete spinal cord injury with walker and knee ankle foot orthosis, and the patients with transfemoral and transradial amputations at that time. Around 1950, Professor Mizuno in Osaka City University imported the word rehabilitation into Japan after studying rehabilitation medicine in Europe. In 1963, 3 major events occurred in the same year. The first is the establishment of the Japanese Association of Rehabilitation Medicine, and this came true with the collaboration between internal medicine and orthopedic surgery. Professor Ueda and Professor Tsuyama, both at the University of Tokyo, greatly contributed to this. The second event was the establishment of the first rehabilitation department among the university hospitals in Japan at the University of Tokyo Hospital. The last one was the establishment of the first vocational school for physical and occupational therapists that was affiliated with Tokyo National Hospital. In 1980, board certification system for physiatrists was started by the Japanese Association of Rehabilitation Medicine, and this contributed to the increase of physiatrists in Japan. From now on, I will explain about the three legal systems related to rehabilitation in Japan. This slide shows the rehabilitation fee in medical insurance system. In 1974, medical fee for physical and occupational therapy was included in the medical insurance system, and in 1981, fee for speech therapy was added. This system, according to the type of rehabilitation intervention, was replaced by rehabilitation fee according to disease categories in 2006. The categories included musculoskeletal, cerebrovascular, cardiovascular, and respiratory diseases, and other categories were later added. In acute phase, up to 6 units of rehabilitation per day, which corresponds to 120 minutes, are covered by the medical insurance, and up to 9 units in special occasions like very early walking exercise. In subacute phase, up to 9 units of rehabilitation per day in convalescent rehabilitation ward, which correspond to 180 minutes, are covered by the insurance. In chronic or post-subacute phase, up to 13 units per month of rehabilitation are now covered by the insurance in limited conditions of patients or with reduced fee. In the medical insurance system, the patient must pay 10 to 30% of the fee according to the age and income. When this system, according to disease categories, was first introduced in 2006, chronic phase rehabilitation was not allowed to use medical insurance. This led to opposition movements by many persons with disabilities who had received continuous rehabilitation in their chronic phase. Regarding this issue, Professor Tomio Tada, Emeritus Professor of Immunology, the University of Tokyo, and also a survivor of severe brain infarction, wrote some articles and performed the signature collecting campaign. These activities led to the coverage of limited rehabilitation in chronic phase by medical insurance. The right down is the book titled My Fight for Rehabilitation by Professor Tada. He was a very famous immunologist, establishing the concept of immune suppression and provided evidence for the existence of suppressor T cells. I learned immunology from him when I was a university student, and he was also a patient at the Department of Rehabilitation, the University of Tokyo Hospital. The next legal system is the long-term care insurance system that started in 2000. The beneficiaries were categorized into two. Category 1 designates persons aged 65 or older requiring long-term care like bedridden, dementia, or support like frailty. Category 2 designates persons aged 40 to 64 who have become bedridden, dementia, and or frail because of the specified 16 diseases and disorders, including terminal cancer, rheumatoid arthritis, spinal channel stenosis, amyotrophic lateral sclerosis, and chronic obstructive pulmonary disease. In this insurance system, the sources of revenue are tax 50% and insurance premium by insured persons aged 40 years or older 50%. The self-expense is 10 to 30% according to the income. Rehabilitation services, which have no limitations in duration, includes home visit rehabilitation, outpatient rehabilitation, called daycare, and rehabilitation for persons admitted to facilities. The long-term care insurance system serves as an important role in the community-based integrated care system, which is defined in the amendment to the related acts for securing comprehensive medical and long-term care in the community. The name of the law is incorrect in the proceedings. This was enforced in 2014. This system comprehensively ensures the provision of health care, nursing care, prevention, housing, and livelihood support, and will be established by 2025, when the baby boomers will become age 75 or above. By this, the elderly could live the rest of their lives in their own ways, in environments familiar to them, even if they become heavily in need of long-term care. You can find in the upper left the primary care physician as a key person for regular health care, and on the upper right, home visit and outpatient rehabilitation that play roles of community-based rehabilitation. The third legal system is the Disability Welfare Services. In 2006, Services and Supports for Persons with Disabilities Act was enforced, and in 2013, this law was revised to act on providing comprehensive support for the daily life and life in society of persons with disabilities. The beneficiaries range from pediatric to the elderly persons with physical, intellectual, and mental disabilities, and also persons with designated over 350 intractable diseases are included. The source of revenue is 100% tax from national and local government. The self-expense is 0 to 10% according to the income. Among the many welfare services, rehabilitation services provide functional training, training for daily living, and vocational rehabilitation. Assistive devices are also provided through this system. These are rehabilitation services in persons with spinal cord injury. These include rehabilitation services in persons with spinal cord injuries, driving a car, or using 3D printed self-help devices. This slide shows the relationship of these systems and primary health care. Medical insurance covers most of the rehabilitation in acute and subacute phase. Though medical insurance also covers limited part of chronic phase rehabilitation, Japanese government recommends early transition to long-term care insurance to cover this chronic phase rehabilitation if the patient can be categorized as a beneficiary of this system. Though the concept of rehabilitation provided as disability welfare services differ from that covered by medical and long-term care insurance, Those who can be beneficiaries may be provided rehabilitation services as disability welfare services. In chronic phases, primary health care provides regular medical examinations as family doctors. In examining patients with chronic disability, these family doctors or primary health physicians are expected to have knowledge of the patient's disability. If these family doctors or primary health physicians are in the position of prescribing or supervising rehabilitation services, they also need knowledge of rehabilitation and need to collaborate with physiatrists who know the patient well, in addition to rehabilitation professionals like physical and occupational therapists who actually provide therapies. In Japan, the number of facilities providing chronic phase rehabilitation, especially home visit, is increasing in these 15 years. The upper right graph shows the number of facilities providing outpatient rehabilitation, which is called daycare, and lower right graph shows the number of facilities providing home visit rehabilitation. However, the quality of rehabilitation services in chronic phase has been pointed out in Japan, so education of primary care physicians is needed. To address this demand, the Japanese Association of Rehabilitation Medicine started holding workshops on rehabilitation useful for general doctors in 2006. In 2017, the Japanese Society of Community-Based Rehabilitation Medicine was established, and in collaboration with the Japanese Association of Rehabilitation Medicine, has been holding workshop for medical doctors involved in chronic phase rehabilitation since 2017, and workshop on home visit rehabilitation for primary care physicians since 2018. Lastly, I will talk about assistive devices and primary health care. In Japan, lack of appropriate maintenance of assistive devices in chronic phase has been pointed out. This may lead to unfitness and skin trouble that may worsen disability. To prevent such situation, education about assistive devices of professionals of rehabilitation and welfare services, and also primary care physicians, may be useful. In addition, our research group considered that education of users themselves may also be effective to capture the improper condition of assistive devices timely. This leaflet, titled For Effective Follow-up of Prosthesis Orthosis, Realize Breakdown and Unfitness by Yourself, was issued last year. In this presentation, I explained how rehabilitation services have been integrated in primary health care in Japan. Thank you for your attention.
네, 발표 감사드립니다.
Thank you very much for your presentation. We do have a few minutes left, so we'll open the floor. If you have any questions to President Nobuhiko Haga, please go ahead. Yes, Director Kim Yong. Director Kim On-yu from Korean National Rehabilitation Center. Please use microphone. Thank you very much for the great presentation. In Japan, for a long time, already rehabilitation service was integrated into primary care and it's well systemized. But in reality, even if we plan when we design, putting into practice is very important, but sometimes there are times that we feel that there are some shortfalls, something to be needed to improved. In the process of that, did you find any shortcomings, and what about your ways to improve? Do you have any plans to improve that? I want to know about that.
Excuse me, improve what? What to improve?
You have already in Japan is a good, I think a good education in primary system, but I think everywhere have a problem. So I wonder which problems do you have now, and it's a resolution. So I wonder.
Thank you for your question. As I stated in my presentation, the main problem is the level of the quality of rehabilitation service in chronic phase has been pointed for many years. It may come from the rapidly increased number of physical and occupational therapists in Japan, while those who prescribe or supervise these rehabilitation professionals are not always educated well about rehabilitation. So the maintenance and increase of the quality of rehabilitation services for the community level is the most important problem, I think.
네, 답변 감사합니다.
Thank you for the answer. Any other questions? Any other questions? Yes, Professor Chang. Thank you for sharing the case of Japan. I was able to learn a lot. Thank you. Pauline Klenit's technical advisor is sitting right next to me, and among her presentation, she said in order to integrate rehabilitation into primary health care, we need to build political commitment and awareness. In Japan, what about the political commitment and alliance of health? Is there any activities? Do you have a case to share?
It's a difficult question, I think. The government has been working for the demand of rehabilitation services in chronic phase with for those with disabilities, and so it's very difficult to answer. I will think deeply and answer later.
네, 그러면
So probably President Haga can have a separate talk, private talk with Professor Chang. Thank you once again. Please give a warm round of applause to President Nobuhiko Haga. Well, we'll wrap up the first session. Thank you once again for joining us today. During the second session, there will be many lectures about practical approaches to expanding rehabilitation service in primary care. We will begin at 1:30. Please join us at the second session. Thank you.
지금부터
From now on, we are going to begin session 2 under the title of Practical Approaches to Expanding Rehabilitation Services in Primary Care. As I said, the theme of session 2 is Practical Approaches to Expanding Rehabilitation Services in Primary Care. 5 presentations will be delivered in session 2, and after all the presentations are over, we are going to have the panel discussion on how we can enhance rehab services in primary care settings. Now, for the first so let us begin session 2. The first presentation of session 2 will be delivered by Dr. Catherine Stent, co-chair of the World Rehabilitation Alliance Primary Care Workstream. Dr. Kate Stead, he's a medical doctor, and she's also a co-chair for the primary care workstream of the World Health Organization hosted World Rehabilitation Alliance. She's a lecturer in the Department of the Family and Community Medicine, Tammany Faculty of Medicine, University of Toronto. The University of Toronto, the FCM, is a World Health Organization collaborating center on family medicine, and Dr. Stead is involved in several projects. So now we'll watch the video.
Good afternoon. I want to live in a world where everyone has access to the quality healthcare services they need, where and when they need them, and without financial hardship. In particular, I have a passion and focus on rehabilitation needs. The reality is, in many parts of the world, people do not have or they cannot access the services that they need. This is a global problem. I believe that every healthcare practitioner can play a role in making change. And the way to do this is as a team, many different professions working together towards a common goal. My name is Kate Stead. I'm a family doctor from Canada and a co-chair for the World Rehabilitation Alliance, which is hosted by the World Health Organization. I've been invited to speak today to share with you changes that are happening at a global level in rehabilitation and primary care, to introduce the new World Rehabilitation Alliance, and to talk about ways that you can make change in helping to incorporate rehabilitation into interprofessional, comprehensive primary care. We all have patients, friends and family, loved ones, people we know, who are desperately in need of rehabilitation services. You know them. The patient who injured his back at work 8 weeks ago and is not improving. The patient with cerebral palsy needing ongoing, interdisciplinary care. The adult in your practice with dual hearing and vision loss who has become socially isolated. There are also people who might not be your patients, but you still know them. Your aunt who had a hip replacement and is learning to walk again. The child in your neighborhood whose language is not developing as expected and her parents think she might have hearing loss. Your friend who has dementia and struggles with getting dressed and planning meals. And the list continues. They all have something in common. They want and need access to quality rehabilitation services to allow them to live at their best. Did you know 2.6 billion people worldwide, that's 1 in 3 people, have conditions which would benefit from rehabilitation? But in many parts of the world, they do not have or they cannot access the services they need. Rehabilitation is often underdeveloped with limited availability across healthcare. Worldwide, rehabilitation needs are increasing at a rapid rate due to population growth, aging, and increases in non-communicable diseases. But in many countries, more than half of people lack access to the rehabilitation services they require. Did you also know rehabilitation is an essential health service and is integral to achieving universal health coverage? It has been shown to optimize functioning, reduce disability, and allow for meaningful participation in activities throughout the life course. And the majority of rehabilitation needs can be met in primary care. I know many of you work in primary care and have colleagues in primary care. However, so we are all on the same page, I'm going to be using the World Health Organization definition. So primary care is a model of care that supports first contact, accessible, continuous, comprehensive, and coordinated person-focused care. It aims to optimize population health and reduce disparities. It is a key process in a health system that provides services all the way through the life course, so from promotion and prevention to treatment, rehabilitation, and palliation. Integrating and expanding rehabilitation in primary care is critical to improving equitable access to rehabilitation. So, the World Health Organization recognized this large unmet need for rehabilitation services and that this was a large global problem. In 2017, there was a call for action by the World Health Organization to strengthen rehabilitation in countries, and the Rehabilitation 2030 initiative was launched with the aim of strengthening health systems to meet this large unmet need for rehabilitation. Since then, the World Health Organization and its partners have been working to produce evidence, so doing the research to show why rehabilitation is so important in health systems, creating capacity, which is taking that research and developing tools and technical resources in order to support countries. Then last year, in May of 2023, at the World Health Assembly, an absolute historic resolution was set forth on strengthening rehabilitation in health systems, and it was adopted unanimously by the 194 member states who were present. While this was happening, in the background, the World Health Organization was doing the research, creating tools, and recognized that we needed a voice to advocate for this. And so the World Rehabilitation Alliance was launched in 2023 to do just this. The World Rehabilitation Alliance, or the WRA, is a global network of stakeholders whose mission is to advocate for the implementation of Rehabilitation 2030. It is a World Health Organization hosted network, and the WRA recognizes rehabilitation as an essential health service. So Rehab 2030 and the World Rehabilitation Alliance are complementing each other. Rehabilitation 2030 is the work that the WHO and its partners are doing to produce evidence, so getting the research, creating capacity, tools, technical resources to support countries. And the World Rehabilitation Alliance is the voice for this. We are raising awareness, creating demand, and mobilizing political will. The World Rehabilitation Alliance has 5 work streams, all focused on different areas of rehabilitation. So there's the health workforce, external relations, health systems and policy research, emergencies, and primary care. Primary care is the work stream that I am one of the co-chairs for. The World Rehabilitation Alliance has 86 members to date, which are organizations from all across the globe. For the primary care work stream, we have an aspiration to enable the optimal integration of rehabilitation and primary care all along the continuum of care. You're probably wondering what we've been doing or what we're doing. So our objectives are, 1, to create a common understanding of the necessity to integrate rehabilitation and primary care among health providers. So how are we doing that? That's through conferences such as today, social media, developing videos, building awareness. The second objective that we have is to engage international associations of primary care and rehabilitation professionals in the development of strategies that advance the integration of rehabilitation and primary care. We launched just over a year ago, and since then we have successfully been able to make collaboration connections with both WONCA, which is the World Organization of Family Physicians, and ICN, which is the International Council of Nurses. And then 3, our other objective is to facilitate collaboration between primary care and rehabilitation providers in the process of integrating rehabilitation and primary care, whether this is on a day-to-day basis, at conferences, at an international level, all across. Why does this matter? So it matters because rehabilitation is a key element of primary care. When we integrate rehabilitation into primary care, we know that patient outcomes improve, including their quality of life and functioning. We have decreased wait times for specialized rehabilitation services, We reduce hospital readmissions, we delay admission to long-term care, and most of all, we increase levels of satisfaction, both for patients and their healthcare providers. Wouldn't it be amazing if in the future anyone who needed rehabilitation services could access them, where and when they needed, and without financial barrier? Change is happening right now. There is a huge shift globally in terms of rehabilitation, and we want to ensure that all rehabilitation providers are a part of this movement. So how can you make change? I have some ideas to get you started, and you can think about what might work for you. In general, when we're making change, we like to think of bottom-up approaches, top-down approaches, and then all the things in the middle. So if we're thinking about some changes that we can make from the bottom up, start a conversation. Think about talking to and educating primary care providers in your community about what you do as a profession. Not all doctors, nurses, community health workers actually know what you specifically do as a rehabilitation provider. And it is really important that you help them to better understand this. So practically, how do you do this, right? So one idea I could think of was offer to have a primary care workshop or a primary care luncheon where you invite all different professions in the community. Everyone comes prepared and they share or explain what their profession does. Maybe you're just talking about a day in the life. Network with these people, get to know them, and develop an interdisciplinary community of practice in your area. Start to get to know people. Another bottom-up approach is education. Let's inspire our next generation of providers. Starting out with these concepts of interprofessional models of care right from the beginning makes such a difference. Again, when you're thinking, well, practically, how do we do this? There are probably lots of ideas. The thing that I was thinking about was in coordinating interprofessional education and training. So if you have students from different rehabilitation disciplines, medical students and residents, having combined classes, shared rotations. And then when we're thinking about top-down approaches, so I would encourage you to work together with your country, regional, or international organizations. Many of your international and national societies are possibly already members of the World Rehabilitation Alliance. I know that our primary care workstream, we currently have 53 members, and they all feel very strongly about the importance of interprofessional primary care and that it needs and should include rehabilitation providers. If your international organizations are not yet members of the WRA, you could consider talking to them about it and encouraging them to apply. They're on our World Rehabilitation Alliance website. There's an area about membership. And then when we want to think about all the stuff in the middle, so we're working from the bottom up in our communities, working from the top down with our organizations, and somewhere in the middle this needs to meet. And this is where building models of care can help. So if you think about building models of care that include teams of different rehabilitation professionals, it can make change. Each country and profession will have different challenges in figuring out how do we incorporate rehabilitation into primary care. Some challenges to overcome might be geography, the availability of both primary care and rehabilitation providers, funding, and things such as this. However, we can and we need to be creative in it. So try and think about how might you do this in your community. It could be as simple as finding a collection of primary care clinics based on geography and link them in a hub with rehabilitation providers or clinics. Or perhaps it's integrating rehabilitation providers into an already existing primary care team or in an already existing network. There are a few really good examples of this. In 2007, Chile's Ministry of Health transitioned from specialized to primary care-centered rehabilitation. They have shown strong leadership and financial commitment from their Ministry of Health, along with evidence-based planning, and this has allowed it to become a sustainable and effective national system. Another example is in the United Kingdom, where they have a first contact physiotherapy model of primary care. where if a patient calls to their family physician's office or their GP's office and they have a musculoskeletal concern, they are automatically booked with a physiotherapist rather than with a family doctor or a nurse practitioner. And this allows them to work together as a team in primary care and address musculoskeletal concerns right away. Other things to meet in the middle that we can think about is community engagement, so educating the public about the importance of rehabilitation and primary care. Once you have a network and you have done this, you can then collectively, as a louder, stronger voice, reach out to local governments, talk to your health networks, and advocate to policymakers where you work to encourage and promote the allocation of funds for rehabilitation services in primary care. You can make change. We can all make change. I really firmly feel this can happen. And our collective goal, of course, is to improve patient care. Patient care will improve at every level of changes you make, from knowing what other providers do and them knowing what you do, to working together in an interprofessional model of care, to advocating to decision makers. At the core of it is what matters to all of us, and that is improving patient care. If you're wanting to learn more, there are some resources available at this link. Feel free to use your phone to get a screenshot of this. And also on my reference page at the end of my slides, please feel free to share my presentation for this purpose. One of the resources I want to draw your attention to is the World Health Organization Basic Package of Interventions for Rehabilitation. This will be a free toolkit that will be available hopefully in early 2025. And it is a guide for primary care professionals to safely and effectively identify rehabilitation needs, provide some low-cost but high-impact interventions for rehabilitation, and it will also serve as a guide for ministries of health in planning and budgeting for rehabilitation in primary healthcare.
Thank you to the National Rehabilitation Center for the Republic of Korea, WHO Collaborating Center, for inviting me to speak with you today. I want to leave you with this. Let's imagine a world where everyone has access to quality healthcare services, including rehabilitation, regardless of their financial means. We can make change. I hope you leave here today with some newfound inspiration on how we can incorporate rehabilitation into primary care. Start the conversation, build networks in primary care, and advocate to policymakers. Let's make change. I'm not there with you today. However, Pauline Kleinitz, who spoke earlier, and Jae Young Lim are. Pauline is with the World Health Organization. She is part of the secretariat that supports the primary care workstream. And Jae Young Lim is one of the WRA primary care workstream members. Please feel free to continue the conversation with them and to ask any questions you might have. I've put my email address on the slide here. Please feel free to contact me. Email me with questions you might have, ideas, and of course, stories of successes. Thank you so much for the work that you do and the work that you're going to do and change we're going to make going forward. I hope that you all have a lovely day.
네, 발표 감사드립니다.
Thank you for the presentation. So the WRI, as introduced, NRC is also involved in research and workforce of the NRC. And for the primary care activities, that was a very detailed and informative presentation. Thank you very much. Moving on, we are going to move on to the second presentation of session 2. Senior lecturer and co-head of the WHO-CC, the Kim Berkeley, co-head of the WHO-CC Strengthening Rehabilitation in Health System, the University of Sydney, Australia, will give us the presentation. The topic of her presentation is integration of rehabilitation into health system. So Dr. Kim has been involved in this research for more than 30 years, and she has led a very innovative approaches. Especially, she's interested in telemedicine, telehealth, and also the task sharing and workforce redesign. So, ladies and gentlemen, please give her a big hand.
Thank you. It's a here this afternoon at this gathering, and I really appreciate the opportunity. So thank you very much to my Korean colleagues for inviting me along today. I've been interested in telerehabilitation and telepractice for the last 10 years, and I'm of the view that it has a great potential to offer us, so I appreciate the opportunity to share that with you and hear your thoughts as well. As an Australian, I proudly acknowledge Aboriginal and Torres Strait Islander peoples as the custodians of the land that I live and work on, and I pay my respects to elders past, present and emerging, and extend that respect to any First Nations people in the meeting today. I will cover the following today. I want to have a brief overview of why we need telerehabilitation, what is telerehabilitation, and some of the barriers and facilitators, as well as how we can move into telerehabilitation as part of business as usual. So why do we need telerehabilitation? This quote is known to many of you, but my emphasis today is on the final phrase, that rehabilitation should be available for anyone who needs it. And I think that telerehabilitation offers us some opportunities in that area. Many of the speakers before me have spoken about the need for an unmet need for rehabilitation, and it's significant. Over 2.4 billion people globally could benefit from or have health conditions that could benefit from rehabilitation, and we are hearing that in some countries this is a challenge for all of us, but in some countries that the unmet need can be as high as 50%, which is an unacceptable position. We have to really have a look at what we can do to address that unmet need. So this is where telerehabilitation comes in my view. It can come into play to offer some opportunities to spread the reach of our scarce rehabilitation resources. The evidence base that has been amassing over some years, it's not just, at times we focus on the post-COVID period because that's where a lot more research has been generated, but there has been research being generated around telerehabilitation, telemedicine, telepractice for some years. And it's coalescing to agree that telerehabilitation can optimise timing, intensity and duration of rehabilitation programs, and to facilitate self-efficacy and engagement with home programs. So it's something that has a lot to offer in terms of that meeting that unmet need for rehabilitation. So what do we mean by telerehabilitation? When I first came into this area in the early, around 2010, 2011, there was a lot of technology that was coming into the health system and into supports and services for people with disability and people with rehabilitation needs. And we had a very starry-eyed view of technology as being an answer, as being a saviour for us. But I think one of the things that we missed was that it's actually not so much about the specifics of the technology, although that is important. It's actually about us understanding how we implement that and how we integrate that into our systems of care, that we don't see it as a separate thing. It's a part of what we do. So the principles of telerehabilitation that are articulated by Alexander in her recent textbook on telerehabilitation identify administrative principles where we look at regulatory guidelines, national standards, policy procedures, quality, governance and reimbursement. So it's not about the tech. In some of a lot of the time, it's about how we are engaging with that and incorporating that into our systems. There are technical issues, of course, right? So we do need to understand the technological advances, the devices that might be needed, privacy and security, the maintenance, the adaptation, the updating, and also considerations of low and high tech. At times we can be distracted into really leaning into high tech solutions when something that is low tech might be a more suitable bespoke option. We also need to look at clinical issues, so training of service providers, as well as helping patients, family members and carers understand what telerehabilitation is and isn't, so that we can get a bit better fit of expectations. We need to look at scope of practice and how that can be managed in a safe way that is really recognising of privacy issues and of meeting the needs of the individual who has a rehabilitation need. We also need to look at ethical considerations around equity, around risks, compliance, do no harm, and individuals' code of ethics in terms of their different professional backgrounds. So there are some very important principles around telerehabilitation that we have to consider in developing these service types. So Russell and Alexander, who have written more recently on telerehabilitation, suggests that there's an extensive range of services that can be provided by telerehab. Prior to COVID-19, in the work that I had been doing, it was a real effort to convince people that service delivery was really accessible and appropriate using digital and technological approaches. People thought of communication technologies, for example, video conferencing, as a way of running team meetings and providing education, but were not really seriously considering it as a mechanism of service delivery. It needed a lot more development for people to look at it that way. So this range of services have now come out as being something that is quite reasonable to provide: education and coaching, counselling, assessment, intervention of all types, monitoring, ongoing monitoring, offline self-management programs and interdisciplinary supports. So it doesn't mean that everything can be provided by telerehabilitation or in a virtual mode or in a remote mode, but it does mean that we need to be considering all of these things. When I first started in this area, people were saying you couldn't possibly do an assessment online, and we have now come to have lots of evidence that is actually suggesting that that is not the case. They also describe models of care that fit within telerehabilitation practice. So centre-based hub and spoke models where there's a professional who then links with another professional and patient at a satellite centre, or there's in-home real-time rehabilitation services from a provider to the patient in their own home or in a location of their choosing. There's some remote asynchronous telemonitoring of patient performance and in-home therapy activities that are supported or supervised remotely by a clinician. So there's a number of different ways that we can engage with the models, and these are only some of them. There are certainly other ones that we can develop. So telerehabilitation can take many forms. It definitely includes service delivery and direct engagement with clients and patients, but it can also be about transfer of knowledge between professionals and care providers from at different places within the rehabilitation pathway. It can occur in acute, subacute and long-term areas. It's a broad range. It can use a broad range of information and communication technologies, from the mobile phone up to remote monitoring, wearable devices, video conferencing, etc. So there's a wide range of information and communication technologies that can be applied. It can include synchronous communication, for example, that video and audio conferencing and chat messaging. It can be asynchronous, where there's store and forward images for consultation, reviewing data obtained from sensors and wearable technologies, and non-urgent messaging on patient portals. A broad range of health professionals can be involved in tele-rehabilitation. So really looking at that interdisciplinary team that we were speaking about earlier this morning, and really mobilising the existing workforce to contribute, particularly in primary care, using information and communication technologies. It also can involve, should involve and will involve service users, patients, family members and caregivers, because that's where the location where a lot of rehabilitation occurs. So what are some of the barriers and facilitators of tele-rehabilitation that we are hearing about in the literature? Some of the issues that we've heard about are about adoption. They interfere with adoption, are organisational and practitioner resistance. People can't visualise what tele-rehabilitation might look like in their context or in their setting, and are limited by the thinking around that. And so try and squeeze in-person delivery of service into a virtual model, and instead of actually really unpacking it and understanding that that might look a little bit different. So that organisational and practitioner resistance is something that is quite a significant issue that we have to really address and grow these conversations around. There's innovation fatigue for some people. COVID-19 had a very big effect on the health system and many people in rehabilitation and community support systems. And sometimes when you start to talk about tele-rehabilitation, I see people's eyes glaze over and they go, we're too busy, we can't do something else that's new or something else that's different. And so we have to really look at how the particular context can manage, and whether we go in with something that is fairly low change, in terms of the cognitive load that's required. Perceptions of inferior quality. People have often said to me, we only do that when we can't see someone. And so that's a perception that we need to challenge and have a look at, because the evidence base is not supporting that perception. I'm not saying that everything can be done by tele-rehabilitation, but I think there are some things that can be done very well using tele-rehabilitation. Sometimes people have focused on high-tech solutions that are out of their reach, so they think, well, we can't do this. We haven't got the resources to have remote monitoring wearable devices. We haven't got great internet bandwidth. We don't have access to video conferencing, high-quality video conferencing. It's about looking at the context and understanding a bit more about that, rather than having that as a perception that stops you from even asking the question. There are resource limitations at both systemic infrastructure level and at the local level. So, as I talked about before, bandwidth and internet, as well as something as simple as access to a mobile phone for staff. Those things can be really significant barriers for people. Perception is that at times is that tele-rehabilitation is for somebody else's context, not mine. And so it's really important for us to challenge that. My view is that tele-rehabilitation needs to be part of all our systems so that we are optimising that scarce resource that we have, which affects all of us in all contexts. There are some issues at times where people get concerned about professional boundaries and scope of practice, where people are not comfortable about delegating or looking at bringing in interdisciplinary approaches. And as was mentioned this morning by a number of our speakers, interdisciplinary approaches are the future of rehabilitation, and tele-rehabilitation is no exception to that. Privacy concerns are a very serious issue that has to be considered. We have to really look at making sure that the engagements we have with our clients, our patients, are protected and are not put at risk. So they are real concerns, but they are manageable, and the platforms are getting much more stringent and rigorous in how they deal with privacy issues. I'm going to jump over that one because I'm running out of time. So health equity considerations is something that people have raised in regards to telerehabilitation as being a facilitator of telerehabilitation, but also as a negative. Some people have seen that, oh, you will only set up telerehabilitation for people who haven't had access to rehabilitation anyway, so they're going to get an inferior service. And that's absolutely not the intention. It's about getting coverage and access for as many people as possible, and that includes a reshifting and shaping of the rehabilitation design. Our speaker this morning talked about inverting the pyramid, the triangle around rehabilitation, having the majority at the specialist centre end, and flipping that around so that we can have much more access. So there are real issues, though, around infrastructure and coverage, access to devices, health literacy concerns, and growing people's awareness and understanding of what telerehabilitation is and isn't. And we do have a dearth of research on telerehabilitation in low and middle income countries, so it is beholden on us to be doing that work to make sure that we are not imposing and assuming that some of the evidence base that we have from the higher income countries applies. So we really need to do some work around that. And we also need to really look at service user familiarity with telepractice, or telerehabilitation. Some people are really on top of it, happy to pick up technology, others will not. So we have to really understand a bit more about that in terms of equity. So some more negative experiences of telerehabilitation. As I mentioned, COVID-19 was a bit of a had a double edge to it. For some people, it was an opportunity for them to go, okay, let's explore this. Let's have a look at what we can do virtually. What can we do remotely? What have we got at our disposal? And it did foster some innovation. But for many people, it was a forced, unplanned, unprepared pivot to online service delivery that people felt very uncomfortable about. So that can be a negative experience that people are holding to say now that telerehabilitation is not good. Whereas I would say that perhaps we need to look at a more measured, prepared, supported way of engaging with telerehabilitation, and not take COVID as the only example that you then base the rest of your practice and service design on. That poor preparation was a real stress for everybody, for families, service users, patients, as well as for professionals. We also need to get better at maximising the features of online ICT options. People at times think, oh, they're very cold and unrelational. I need to be in the room with someone to form a relationship. The body of evidence is growing to say that that is not the case. You might need to build that relationship in a different way and be much more purposeful and considered in the way that you do that. You don't just get onto your Zoom meeting and go straight into doing an exercise with a child. You have that conversation like you would in a waiting room, and when you're going to your room, you have to make sure that you are being purposefully relational, but it's not precluded by telerehabilitation platforms. So that thing about therapeutic alliance and professional relationships are not out of reach in a telerehabilitation platform. There are some concerns about task sharing, task shifting, safety and appropriateness, and so we need to be aware of that. I'm going to talk to you just briefly about Project ECHO, which is a systems change approach that has been developed over some years in the US. Sorry, I've just changed the order of my slides. So it was developed in the University of New Mexico in 2003, and it stands for the Extension for Community Health Outcomes, ECHO. And it's an approach that is about telementoring, linking with providers to providers in a case-based model. So it's with working with somebody in a remote location and having somebody who has particular expertise or knowledge in another location, supporting them with managing that client. So it's not direct service delivery, it's provider to provider service delivery. So it's described as a tele-mentoring approach, and it's really grown in terms of its uptake around the world. There's now 1,300 ECHO hubs in 200 countries supporting 7,000 programs worldwide, and that includes rehabilitation, tele-rehabilitation approaches. And it's recognised as a global success, and it's been a way of bringing the expertise and knowledge of a scarce resource, such as we have in rehabilitation, to the community, to a variety of different professionals. So their sort of principles are to amplify, using the use of technology to expand scarce resources, aim for best practice by sharing knowledge throughout the system, collect data and evaluate and monitor outcomes to make sure that things are working well, and that case-based learning so that you're managing complexity and getting support and advice for people who are in those primary care settings. It's also been expanding out into education, disability and other areas. So it's quite an interesting model. So the other thing that I think is a real advantage or something that's promoting tele-rehabilitation is that there is a real growth in the evidence base. Since COVID-19, there is so much more literature out there about telepractice, telemedicine, telehealth and tele-rehabilitation. And so we need to consolidate the tele-rehabilitation evidence and really understand a lot more about that in diverse settings. And we need to focus on research that's integrating tele-rehabilitation into health systems, not just individual instances or examples of tele-rehabilitation in a particular setting. And we need to really look at how we can develop those resources to support implementation. So how do we shift to making tele-rehabilitation part of business as usual, which is what I mean by integration into health systems? So I think that we can, lean back in here to our Rehab 2030 areas for action that will guide us in the steps that we need to take to integrate tele-rehab. It's a systems issue. It's not just a specific practice issue. It's a systems issue. We've moved beyond the proof of concept phase, and we must explore these opportunities for system change. We need leadership and policies that are explicit in articulating the value and the role of tele-rehabilitation, especially in primary care, where we know from the conversations earlier that a lot of rehabilitation could and should be happening. And we need to recognise the significant benefits for people with rehabilitation needs if we adopt this approach. So we need to look at service model designs. We need to look at scalability so that we can get coverage, not just have isolated examples. We need to continue to build an evidence base that is essential to share the system experiences that we all have so that we are articulating the next steps forward and sharing that in our rehabilitation community. One of the significant factors in the uptake and implementation of tele-rehabilitation is workforce readiness. And it's about also workforce preparation and also about workforce buy-in. It can falter or succeed on the back of the workforce that we are trying to engage with here. So the Calder framework is an evidence-based workforce transformation tool that I've been looking at for some years, but I think is really something to consider in this context. And it's applicable in settings both community and acute, and really helps us to engage with and include the workforce in the shape of service design, and that's how you get the buy-in. So it's something that I think we might need to be thinking about. As I mentioned earlier, ECHO is another model that I think we can really look at to lean into their experiences and understand how that might help us to shape tele-rehabilitation service design. And one of recent review of Project ECHO globally found that Project ECHO was one model, but it had very many different implementations for innovation. So that's what I think we have to be looking at with telerehabilitation. It's not about being prescriptive and kind of diminutive in the way we approach this. It's about having a broad model that we are then able to fit for purpose. I also think we need to lean back into one of our WHO resources around workforce capability and really look at this with a telerehabilitation lens. What is the workforce capability that we need to be able to succeed with implementing telerehabilitation with our workforce? So we need to shift our thinking to be looking at fundamentally that telerehabilitation is not about exploring individual interventions or technological approaches to adapting a systems-focused view with telerehabilitation as a mechanism of support. We must grow this discourse and we must grow the systemic evidence base. So in closing, I'd like to suggest that we as a rehabilitation community must explore all components of the rehabilitation pathway to develop an ecosystem that includes telerehabilitation as a key component of our service systems to achieve our aim of rehabilitation for all who need it. Thank you.
네, 발표 감사드립니다. 원격
Thank you very much. So that was a very good presentation regarding the telerehabilitation. Dr. Kim Berkeley will join us for the panel discussion later. So ladies and gentlemen, please give her a big hand.
네, 다음 발표는 WHO 1차 의료에서
Next, we'd like to invite consultant Ayabana Yeboah Tana, who will be talking about developing rehabilitations and assistive products provisions in primary care. Dr. Tana is a specialist in rehabilitations and family doctor, and also she has over 14 years of professional experience in rehabilitation and assistive devices and founded Ghana's first multidisciplinary rehabilitation medicine service. Currently, she's a consultant to the WHO rehabilitation program at its headquarters in Switzerland, where she plays key role in leading the development of WHO's basic intervention package for rehabilitation. The innovative tool provides primary health care workers with the training and support they need to effectively and safely deliver a limited range of the prioritized rehabilitation intervention. Please watch the video.
Hello, my name is Abena Tano with the WHO Rehabilitation Program, and I'm thankful for the opportunity to present on developing rehabilitation and assistive product provision in primary care in low-resource settings, approaches, and WHO tools. So we already know that 2.6 billion people, and this number has been updated recently from 2.4 billion, 2.6 billion people experience health conditions that could benefit from rehabilitation. Less than 50% of these people receive the rehabilitation services they require. And so in 2017, the WHO Rehabilitation Program launched the Rehabilitation 2030 agenda with the vision to ensure that everyone who needs rehabilitation receives quality services to optimize and maintain their functioning in everyday life. So the goal was that rehabilitation should go everywhere. Everyone should be able to have access to rehabilitation. And they also did realize that a large majority of rehabilitation needs can be met in primary care, because we all recognize that majority of the people would first present with a health condition in primary care, and that is where the diagnosis is usually made, or there are functioning problems identified and referrals made to other services, so secondary or tertiary services. However, there's a gap. Even though primary care is where most of the patients would go to first of all when they have a health condition, the rehabilitation access is not the same when you compare it to rehabilitation in secondary and tertiary care. there is a huge gap. And why is there a huge gap? So WHO looked at the ongoing challenge in access to rehabilitation in primary care and identified three main reasons why there is a challenge. First of all, limited access or demand for rehabilitation in primary care. A lot of people do not know the benefits of rehabilitation, and so there's reduced demand for it, especially in primary care in low resource settings. And then limited workforce and services. So in primary care settings, you don't have a lot of rehabilitation specialists. You rather find more of the physical therapists, occupational therapists, speech and language therapists, rehabilitation doctors being concentrated more in the urban areas, in the secondary and tertiary settings, leaving the primary care settings not having access to them. And also we know money is needed to do a lot of things, and especially in the low resource settings where there's limited funding to improve workforce access and build the services in primary care, of rehabilitation in primary care. So all these three contribute to the reduced access or the ongoing challenge in access to rehabilitation in primary care. WHO, in an attempt to sort of solve this problem, has developed a number of technical tools for health system strengthening, and majority are from the rehabilitation program. So looking at products that go into leadership and governance, information systems, financing, workforce, improving the workforce that will be able to provide or deliver rehabilitation in primary care, service delivery, which is very important, emergency, and then assistive technology. So all these are tools that help to strengthen the primary care system in addition to the other health systems. And when we look at service delivery, there are two main tools delivered by the WHO rehabilitation program. The first, or the ideal, is the package of interventions for rehabilitation. This is a list of interventions with their consumables and equipment required that can be delivered right from primary care through to secondary and to tertiary level. And they are to guide ministries of health, governments on how to plan and budget for rehabilitation in these settings. They can also be used by rehabilitation specialists to know how to deliver these interventions across all the levels of the health system. So ideally, primary care settings are supposed to have rehabilitation specialists who would be able to deliver the ideal interventions in primary care. We, however, know that based on the research that went into the challenges to accessing rehabilitation in primary care, we did notice that there's a lot of difficulties or challenges. And so WHO is developing a product which would use task sharing to be able to bridge that gap, to be able to make sure that those in primary care are not left out. It's an interim measure to be able to increase access to rehabilitation in primary care. So the WHO basic package of interventions for rehabilitation, or the basic PIR, is a tool that is being developed to bridge the gap between rehabilitation in primary care and rehabilitation in secondary and tertiary care. So when we look at the basic package of interventions for rehabilitation, or the basic PIR, our target audience is doctors and nurses through a task sharing approach. So doctors and nurses working in primary care settings. And it was developed from the package of interventions for rehabilitation. When we are done and hoping to launch it in May 2025, there will be three core resources: a manual which will support the clinical making decision making in primary care for the primary care workers, a blended learning package including online and face-to-face training, and an implementation guide. One peculiar thing about the basic PIR is the fact that it is focusing on functioning and not health conditions, because we do realize that especially in low resource settings, at the primary care level, they do not have adequate diagnostic tools to confirm a diagnosis, and so it might be difficult to train them to provide rehab based on health conditions when a confirmation has not been made or cannot be made at the primary care level. And so when you go on the WHO website, there's an information sheet that outlines the process we've gone through in selecting these interventions, in developing the basic PIR. Again, in selecting the interventions, we have looked at low cost, high impact, evidence-based interventions for rehabilitation, which were selected from the package of interventions for rehabilitation. And we have looked at that because we know that that would be feasible for primary care workers to use at the primary care settings, and also to promote referral to rehabilitation and other health and social services as well. We also would like to reiterate the fact that developing the basic PIR is not meant to replace rehabilitation specialists or the need for rehabilitation specialists in primary care, but to build a demand for it. So it's going to build a demand. When people realize that rehab is important in primary care, then governments will be able to train more rehab specialists and be able to send more or incentivize more rehabilitation specialists to work in these primary care services. And so when we have trained primary care workers in using the basic PIR during our pilot studies, we have heavily involved rehabilitation specialists to serve as mentors for these primary care workers. When we delve a bit deeper into the basic PIR, it has 8 rehabilitation domains, spanning from mental functions, hearing, speech and communication, vision, swallowing, respiratory and cardiovascular, motor functions and mobility, pain, self-care, and participation. And under these 8 rehabilitation domains, we have 20 functioning domains. And we also guide the primary care workers on how to take a patient through how a patient would go through the journey when they come to a primary care setting with a presenting complaint that might benefit from rehabilitation. So they take a history, they need to rule out red flags, and we'll talk about the red flags soon. They would use they'll go assess to confirm or rate the level of difficulty. They will refer to a rehabilitation specialist if there's one available and accessible. And if not, then they will deliver care based on the assessment and also monitor the care provided. Always be in touch with or referring to a rehabilitation specialist if one becomes available along the way. And the delivery of rehabilitation in primary care for non-rehab workforce the training goes through 3 steps: assess, deliver care, and monitor. So again, let's look at the red flags. We brought in the red flags because we did acknowledge the fact that when you are training the non-rehab workforce, so the doctors, nurses working in primary care settings, they need to be able to identify red flags or signs and symptoms that indicate severe health conditions that would require immediate management or referral to a specialist, a medical specialist, whilst withholding rehabilitation in the meantime, so that these red flags are managed or considered. And one primary thing or one major thing in the basic PIR are rehabilitation handouts. And these handouts help the primary care worker, first of all, to know the kind of interventions, the education and advice to give to the client or the patient. And they also serve as tools to be given to the patient to go home to continue the exercises, coming, or the interventions, and then would come back for review with the primary care worker at the primary care setting. In terms of implementing, there are key considerations for implementing or using the basic PIR in a primary care setting. So it can be used alone, or it can be used in conjunction or to complement other WHO primary care products. One major one is the training in assistive products, the TAP, by the assistive technology team, the MHGAP for mental health conditions, the PEN package for management of NCDs in primary care, ICOP for the elderly care in primary care, and the vision and hearing primary care tools. So they can be combined or used alone, or combined with the basic PIR, or the basic PIR can be used alone. When we go a bit deeper into the training in assistive products, it's a tool developed by the assistive products team in WHO to train primary care workers on how to provide assistive products. And it's an online tool, and we have also in the basic PIR developed links to this training in assistive products. So for example, when you look at interventions for muscle strengthening, we have listed the possible assistive products that can support someone who comes to the primary care setting with muscle weakness. So for example, the use of a walking aid, transfer board, wheelchairs, portable ramps, or grab bars, all to supplement or all to support the provision of rehabilitation in primary care. So in developing the basic PIR, we've worked with a team of technical working group members, and we've also piloted it in 6 countries. Currently in the 7th country, we have piloted it in Fiji Islands, Ghana, Uganda, Pakistan, China, Tajikistan, and currently in Tanzania. So these are a couple of pictures or photos to show how the training has gone. There has been very, very, very good reception by the countries where primary care workers in the countries where we have piloted this product, and people are eagerly anticipating the launch of the product, which, as I mentioned, by May 2025, we're hoping to launch it. So in summary, there is truly an ongoing challenge for rehabilitation in primary care. A lot of people, millions of people, lack access to rehabilitation, especially in primary care in low resource settings. The WHO is working on the basic package of interventions for rehabilitation, which is one of the WHO tools, in addition to the training in assistive products that seeks to bridge the gap to rehabilitation and assistive products in primary care through task sharing. Thank you very much. And if you require any further information, please feel free to contact us through this email address. Thank you very much.
네.
Thank you very much, Dr. Abana Tanor. She talked about developing rehabilitation and assistive product provisions in primary care. Let me introduce the next presenter. We have with us the primary care and integrating rehabilitation into primary care. We are listening to the case of Australia and also many different countries in Korea. And I believe this is a great chance that we are hearing the case of other countries. That is why we have prepared the next presentation. National Rehabilitation Center is a collaborative body of the WHO Collaborative Center, and we will invite Dr. Onyu Kim, Chief of the Spinal Cord Injury Rehabilitation Department, the National Rehabilitation Center. Dr. Kim is currently leading the international cooperation in the field of the spinal cord injury rehabilitation, robotic rehabilitation, and he's also a member of the various academic committees, including the Korean Rehabilitation Medicine Association. Please welcome Dr. Kim.
네, 소개 감사.
Thank you for the kind introduction. I am from the Department of Spinal Cord Injury Rehabilitation of the National Rehabilitation Center. International cooperation team is under the Department of Spinal Cord Injury Rehabilitation. So our international collaboration team consists of 3 people, including me and also the MC of the event. Today, the topic of my presentation is expanding rehabilitation through international cooperation, harnessing global networks. I will first give you the introduction of NRC and what kind of roles we play. And also as a WHO collaborating center, I would like to talk about the roles and missions that NRC has. If you look at our mission, NRC's mission is to create a healthy world for people with disabilities, and our vision is to build an institution that leads the future of rehabilitation. And our core value includes dedication for mission, collaboration for communication, and innovation for evolution. Let's take a look at the history of NRC. NIC was established in 1986, and in 1994, Rehabilitation Medical Institution was established. In 2001, we were designated as a responsible administrative institution, and in 2008, we opened Rehabilitation Research Institute. In 2010, we constructed a new ward with 100 beds, having total 300 beds in total, and we achieved national accreditation standard in healthcare service in 2014, and from 2017, we were designated as a WHO collaborating center for rehabilitation, and we got redesignated recently. Here you can see some key functions for NRC. So first of all, we have a role as a rehab hospital. So we provide a specialized rehab medicine for patients, and also we have a health checkup services for PWDs. And education and training is another our key focus area, especially the driving education for people with disabilities, disability awareness program, disability prevention education, and education for patients and caregivers. And we also have a Rehabilitation Research Institute, and they conduct researches on PWD health system and policy, assistive technology, and clinical research on rehabilitation. And as a WHO collaborating center for rehabilitation, we provide supports for health and rehabilitation in WIPRO, and we provide disability data and health information to strengthen the healthcare system. So let me delve into the details. As a rehabilitation hospital, we have 264 beds with 16 departments. We have robot rehabilitation room, including, and also we have a walking assistance lab in order to provide a tailored rehab to patients. And we also have a cognitive rehabilitation clinic, sitting posture clinic, and spinal cord injury rehabilitation clinic. And for adults and pediatrics, we have day center, and also after discharge. In order to ensure successful re-entry into community, we provide community reintegration program. Also for Korean PWDs, we have the professional health screening center. And regarding the PWD sport, we provide various training programs. And also, after the patients return to home, there are needs for retrofitting the homes to their needs, so we have a program called Smart Home. As for Rehabilitation Research Institute, we plan and implement researches with the multidisciplinary research team comprised with physicians, clinicians, engineers, and researchers for people with disabilities. So we have an open platform for assistive technology R&D. Through this platform, the people with disabilities can have a discussion and also raise their needs about the technology that they need. Our main research areas include the health system and policy for PWD, assistive technology, and clinical research. As a WHO collaborating center, from 2017 we were designated, and in 2021 we were redesignated. and head of the center is the president of NRC, and International Cooperation Committee is in charge of actual operation. If you look at the TOR for 2025, you see that first of all, we support to implement strategic plan for strengthening health system in the Wipro region. Second is to support to strengthen health information system, including disability functioning data set. And third is to provide implementation for the healthcare framework on rehabilitation through training on rehabilitation workforce. So here you see the 5 areas that where we are involved as the WHO Collaborating Center. The first is to build rehabilitation capacity and improve rehabilitation service quality. Second is to provide technical support to strengthen health information system. And third is to host international workshops and seminars on rehabilitation and disability. And fourth is to provide international training program for rehab workforce. And the fifth one is to attend various kinds of international meetings and conferences. Now, for more detail, let me talk about our activities. So with regards to the building rehabilitation capacity and improving rehabilitation service quality, so for this, every year, we have a workforce exchange meeting between Korea and Japan. So we do have a representative from the National Rehabilitation Center for People with Disabilities in Japan. And we have conducted the regular exchanges, and we have dealt with various topics including COVID and rehabilitation, rehab for drivers with disabilities or stroke patients, community reintegration support, and assistive technologies. Also, we have translated the WHO Global Report on Health Equity for People with Disabilities, and we published that translation. And outside this room, you can find out that book that we translated. And as a member of the WRA, we are also engaged in various activities. World Rehabilitation Alliance, or WRA in short form. So for this, we participate in workforce and research areas. So for WRA, it pursues the evidence-based advocacy activities to support rehabilitation and raise public awareness, and it strengthens the rehabilitation network to promote the knowledge sharing among the rehabilitation professionals. Second is to provide technical support for strengthening health information system. And one of our works under this is INSKI. So in 2017, we implemented the INSKI together with the ASCOD and ISTRS. So we conducted a survey to collect experiences of patients with the spinal cord injury from the communities, and NRC was involved in this INSKI survey. So in 2017, together with the Korean Spinal Cord Injury Association, we conducted the huge database for 892 people with SCI. And then the second INSKI survey was conducted in 2023. So we also took part in the INSKI survey, this time more with the diverse institutes, including the Busan Yangsan hospitals and also the Korean Spinal Cord Injury Association and several public hospitals, as well as NRC and the International St. Mary Hospital. So total 958 individuals' data were collected in the database from Korea. So there were about 40 countries around the world participating in the INSKI, and we were one of the top 5 contributors of data. And so this data, I believe, could provide an important source of knowledge, not only for the functioning of the people with SCI, but also for their return to society and how we can successfully manage the smooth transition into the community with improved quality of life. The third is to host international workshops and seminars on rehabilitation and disability. So we have held various forums and workshops from 2018. As you know, the WHO Cooperation Forum has begun and continues since 2018, and we have also conducted several international seminars and also the training programs for foreigners. So from 2016, you can see that we have held the various regular invitational training programs, starting with the Colombia. And also we have the several training programs for rehabilitation specialists. And so far we have invited specialists from China, Egypt, Thailand, Mongolia, Colombia, Uzbekistan, Vietnam, Malaysia, Qatar, Japan, and Nepal for the training programs. We also have one-day visit tour program. So various associations and academic societies as well as organizations have visited the NRC, including the Mongol Pediatric Rehabilitation Hospital in Mongolia. They also visited us this month, and ASCON last year visited the NRC. And also the DPI Korea and Global visited the NRC, and East Coast visited the NRC last June. From 2019, we have held the Lee Jong-wook Fellowship Program, and we actually took part in the program as well. So it's not a short-term training, but it's a long-term training with at least over 1 year. And we have 3-month invitational training programs. And every year we have different topics. So about 4 people from Cambodia, including the doctors, nurses, and also the physical therapist, they are invited to NRC for this Lee Jong-wook Fellowship Training Program. We also have the on-site meetings with the trainees. So we have the common sessions where all the doctors, nurses, and also physical therapists all are combined. And also we have separate courses. We also have a training program to deepen their understanding in Korean culture, as well as in Korea's rehabilitation and the people with disabilities sports at special lectures. And that's not the end. After the training program in Korea, we actually gave them the assignment. So we give them the long-term and short-term assignments, and then a few months later, we actually visit hospitals in Cambodia, and we have a meeting where the Cambodian trainees have to share and present their plans, and also we do the on-site monitoring, whether their plans are well implemented, and also whether all the donated equipment are well under operation. So we do also have the checking for that. And not only that, we do have the training program to teach their colleagues on site. And based on that, in order to develop a better course for rehabilitation training, we also conduct a qualitative research on the satisfaction of trainees. And also during the COVID, the access was restricted, and at that time we conducted the virtual training. And I believe that there are very clear pros and cons between the virtual and on-site training. So we also study these differences, and we have several hub hospitals, including the Phnom Penh and the Battambang. And centering around these hospitals, actually various people came and participated in the training. And we wanted to know what kind of changes have occurred after they returned to their home countries, especially in terms of the patient satisfaction. So for this, we again conduct study. And we are engaged in various conferences, including the Rehabilitation 2030 meeting, WHO WIPRO meeting, ASCON meeting, and also we regularly participate in regional forum of WHO Collaborating Center in the Western Pacific, and we have held the WRA launching event and several meetings. Our international cooperation team is dedicated to promote Korean rehabilitation techniques on a global scale, and we utilize our extensive network to exchange information, and we now create a new TOR as we prepare ourselves for the redesignation of the WHO Collaborating Center. And also, in order to improve the rehab services, we will continue to organize this kind of event, and we will also utilize the networking opportunities in order to build a strong and solid cooperation system. And with that, thank you very much.
네, 김원윤.
Thank you very much. That was the presentation by manager Kim Oh-new, and she talked about the NRC and its activities for global network and cooperation. From now, we are going to have a short break. So for about 20 minutes, we will have a break. Coffee and refreshment are prepared outside the hall, so please do enjoy, and we'll come back in 20 minutes. So we'll start at
네, 이제 이
Now we are going to have the final part of session 2. So this session will focus on the rehabilitation in primary healthcare, needs, priorities, practical approaches. And Professor Bok Soo-kyung will give us the presentation. She's a professor of the National University Hospital, and he's especially interested in the cancer rehabilitation. And please give him a big hand.
Good afternoon, ladies and gentlemen. I was just introduced by the MC. I'm Professor Soo-kyung Park of Chungnam National University Hospital. When I was asked to make a presentation, I was hesitant because it talks about health network for the disabled, and if I don't be careful, I might be criticized. But in front of that title, there's a community health network. So I thought about making a presentation on what we are doing. So I felt much comfortable. What you are looking at right now is the current community system, how we deliver the health system. When there is an accident, you are admitted to the hospital. If not, then you are admitted to the rehabilitation facility, and also you get treatment. And probably you can be cured. If not, then you can continuously receive rehabilitation. So you will be register yourself to the regional office as a person with disability, and that's where the local disability persons health center plays the role. And you will be connected with local infrastructure for medical care, and then if there's any issues, you will be referred back to the medical hospitals. And another one is, you can see here, is local disability healthcare center. Some of the person with a disability can stay home, or if there are unmet needs, then we can refer them, and then they can come back to the healthcare center or disability healthcare center. But if they are perfectly cured, and then they can go home, or they can continuously use the regional facility. And then there's a CVR. And mostly primary care center plays its main role. So they do the core work, and CVR is provided. Among the people with the disabilities, some of them stay at home. They can leave their home. So we do have this system of linking the people with the disabilities and also the specialists or doctors visiting their home. So in 2017, based on the Regional Disability Health and Medical Care Center legal law, which was enacted in December of 2017, this came into being, and the Regional Disability Health and Medical Care Center played a key role. objective is to support people with disability in making autonomous decisions regarding their health and medical welfare service, enabling them to lead healthy and independent lives. What you are looking at right now is the regional distribution status of the regional disability health and medical care centers. As you can see here, we can see the center, 2 located in Seoul Metropolitan City and 2 in Chungcheong area. And as you can see, we are surrounded by oceans and mountains, so it seems like it's well distributed. But if you look at carefully, you can see that organically from 2018, the Regional Disability Health and Medical Care Center coexist. I will explain the disability health network in 6 areas. So mainly you can see that the we do is divided into 6 sectors. About 1.5 million and 70,000 are people with disabilities. And we have arranged our database, more than 10 million were registered. When we look at the disability registrations, the severe and less severe can be categorized, and quite a lot of severe people with disabilities are registered. And I believe the people with severe disabilities are registered to get the rehabilitations. The pointer is not working. Anyway, and there are many referrals from the hospitals. They are connected to the Disability Service Center. More than 50% are referred. And also it is connected to the community-based rehabilitation centers. So financial support or assistive devices can be provided. So those are the disability welfare service that we provide. One of the major work that our regional center does is the birth of the pregnant women with the severe disabilities. And we try to provide support to these pregnant women. From 2018, about 58 pregnant women were registered. More than 40% of the pregnant women are with the severe disabilities or intellectual disabilities. And there is a regrettable things. More than half of these pregnant women are women with intellectual disabilities. I mean, the fact that they are intellectually disabled people doesn't mean that they cannot get pregnant, right? But the reason that these people with intellectual disabilities have unwanted pregnancies, and although we are involved in the delivery, there are many difficulties in child care. Some of them have some difficulties in hearings and also sight as well. And we were able to support them in the beginning, but later part, our connections were disconnected. And also there are women's organizations with pregnant women with severe disabilities. So when they register themselves, we explain them what to do. And then even after their delivery, we try to support them. I believe these are our goals. First of all, we would like to complete the regional distribution map of persons with disabilities. We would like to identify and understand the characteristic of the disability by type and by region. And also by accumulating the data, we would like to identify their special features. Third, this is our hope. As long as we have the data, we can come up with the predictive models. Using AI, we hope to complete the predictive models for issues that may arise for persons with disabilities. So we hope to carry out the work of completing the characteristic and prediction models for the people with disabilities. This is our web page. If you can see our web page, all informations are uploaded. And if you look at here, more than 7,940 people have accessed our homepage, and already more than 5,000 people have used our homepage. We try to host different kinds of events and also souvenirs. And when they get access to our webpage, they can see the policies. And there are more than 23,000 of the YouTube video, which is medically related video contents uploaded. And We want the people with the disabilities to join and then to watch our videos, to look at the policies that they can enjoy. I mentioned the 1.5 millions are people with disabilities, and also there are more than 200 institutions. 150 institutions, but after careful calculation, we found out there are 200 institutes, and then we signed the MOU with more than 43 institutions. So we registered themselves, we provide training and educations, and we formed 5 committees. We have Disability Healthcare Committee, Medical Advisory Consultative Meeting, National Disability Healthcare Education Network, Rehabilitation Service Network. So we have built the network. We also look at the Regional Health and Medical Welfare Network. More than 29 institutions are appointed. We select general practitioners, and also we provide educations on disability-specific health care. And then we talk with the internist, and they said that they don't know how to provide treatment. So what we did is we held the meetings to establish the network, and we created the disability medical health promotions video, and then we introduced the disability health advocates, medical devices for persons with disabilities. Some of the people with disabilities told us that promotions is not well done. So we tried to create video, tell them about how to make most of the medical devices or carry out health checkup, or how to visit health centers for persons with disabilities. We also created guidebooks for them. Now, of course, based on the community-based rehabilitation centers, we operate regional health and medical welfare network. So we have different categories. First of all, we have the welfare institution, disabilities health advocate, disability-friendly health and medical institutions, and also rehabilitation institution, etc. If you look at, I'm the head of the center. We have 6 employees, and we don't provide direct service to the patients, but we focus on the rehabilitation. We do have physiatricists, the rehabilitation specialist, and also we have the disability welfare service specialist, and we carry out educations on stroke and risk management, provide preventive exercise techniques, and that is a secondary stroke prevention program we provide, and also we provide speech therapy for aphasia and high blood pressure diabetic management educations. During the COVID-19, there were a lot of issues, especially related with depressions, regardless of whether you are people with a disability or not. So we try to provide psychological support for anxiety, stress through various programs such as therapy or music therapy. We started from this year, which is one-to-one home care support for elderly people with disabilities. We have about 10 elderly people, and then they come to our program, and people with disabilities, we believe that they are getting a lot of help. Now, there are a lot of adolescents with disabilities. As you can see here, we try to provide horse riding program. As you know, children with intellectual disabilities, if they join the horse riding program, it helps a lot. So we provide them, and also to the parents of the children with the brain disorders, we try to also provide special program. We have a unit where children with the brain disorders are stayed. So we provide them the information about what kind of guidance or welfare service they can enjoy from the government. We provide 2 education. First, our target audience is medical personnel and also the prospective public health care professionals. Prospective means students at medical college or at nurse school. So before they get a professional degree, they can get a lot of educations about the people with the disabilities and disability-related institutions. So we want them to understand about the health rights of the people with the disabilities, including understanding the Disability Health Rights Act. And we want to teach them how to communicate with people with the disabilities and improve awareness about the disabilities. And also, third, we want to educate them about the proper health management, like correct medications and guidance and emergency response. If something happened, they don't know what to do. So we try to educate them in a daily life, and more than 1,000 people received education and training from us. Secondly, in providing education, people with disabilities and their families, we don't know to what extent they actually understood our education. So we focus not only the people with a disability, but also their families, like proper health management, physical health management, because these people can also suffer from diabetics or also high blood pressures or infectious disease, etc. So during the COVID-19, they were also saying that people who use sign language, they will not get infected. So we try to give the right information, and also who suffer from the chronic disease, eye disease, we try to help them to prevent them. As I mentioned before, for women, the pregnancy and also birth control and birth delivery, we try to educate them, but we wanted to focus on the pregnancy and childbirth for women with a disability, including birth control education and alleviations of the menopausal symptoms for older people. So we help them to people with women with disability. We try to help them to deliver the babies, but we hope in the future to give more help and support to the women, elderly women with the disabilities in overcoming menopausal symptoms. Now, regarding CBR, community-based rehabilitation, the directions and also the definitions, some are a little bit confused. The CBR is provided by primary care. Whenever there is an event, we try to promote CBR by building a booth or exhibition booth or distributing information. Our counterpart is primary care, but there are a lot of reshuffling of human resources. So we need a continuation. That's why we try to have a discussions on cooperation for healthcare services and rehabilitation service delivery in the regions together with the CBR and the primary care. And also we continuously operate an online rehabilitation program. They told me, each primary care team, that they don't know what to do when they are faced with people with severe disabilities. So I visited them, especially like bedridden patients with severe disabilities, and we asked them, what are your greatest challenges? So I visited them, I heard their views. If necessary, then I sometimes try to help them for the ADR transfer, and I provide goods and services or anything that they might need. I guess after that, our relationship with the primary care really improved. Just like that, the next one is a case management, how we can provide support for the case management, especially for the practitioners. When we tell them about the case management, they have to have a full understanding about the case. As a doctor, I cannot do everything from A to Z. So people with the disabilities, we need to teach them about the disease like arthritis or cerebral disease or any kind of disease, and when we gather together what we need to do, or primary care and then CBR, what and where we need to focus on. And sometimes they don't know what are the disability welfare service and how to allocate the resources, especially about the assistive devices, how we need to provide them. We don't know, so we always discuss. So we try to build the regional disability health and medical care center case management, acute medical institution, rehabilitation medical institutions, welfare institutions. We form a network, And also, there are internal resource connections like social work team, regional medical institution, assistive device centers, medical welfare centers. It is all connected. And also within the health centers, we connect in-home healthcare service, protection service, hospitalization center, case management. And also, there are special center where it provides support for the people with a disability to get a job. Now, up until now, I've been talking to you about people with a disability, how we can help them, educate them, and manage them. But now I'd like to tell you about the rehabilitation medical service model. So the first stage is acute medical institution. We provide rehabilitation service, but after a certain period, and then there is rehabilitation medical institution or so-called recovery hospital. They are admitted, and then intensive rehabilitation treatment is done. And if they cannot be fully recovered, they go to a long-term care center, long-term functional recovery center. So starting from the recovery center, so the living and maintaining center, I guess this is the basic fundamentals for the rehabilitation medical service model. So one of the slogans I'm showing you is people with disability, connecting health and seeing hope. You can see the hope if you are health. So if the regional disability health and medical care centers that I do establish a health network for person with a disability, I believe we will see the improvement in their health and hope for the future. Thank you. Thank you very much, Professor Pok. He talked about the community health network for the disabled through the Health and Medical Care Center for Persons with a Disability. Thank you very much. Thank you so much for paying attention to all the presentation, and my special gratitude goes to the 9 speakers for presenting. We will invite all the speakers and the moderator to have the panel discussion session. Those of you joining us via online, if you have any questions, please leave them in the chat box so that we can address them. We are also currently broadcasting live through YouTube channel of our National Rehabilitation Center account. If you have any comment, please leave them on the YouTube.
네, 지금부터 패널 토론을 진행하도록 하겠습니다. 패널
Now we will begin the panel discussion session. So I would like to invite Professor Yong-il Shin of Busan University to the stage, as well as all the speakers for panel discussion session. Professor Shin Yong-il of Busan University, he got his PhD in Jeonbuk University, and also he got his MD in the same university. And from 2010, he served as a professor of the Rehabilitation Medicine Department of the Busan University. So I would like to now hand over the microphone to moderator. Ladies and gentlemen, please welcome him with a big hand. Thank you very much for the introduction. First of all, it is indeed a great pleasure to moderate this panel discussion session for the 2024 WHO Cooperation International Forum. And I would like to thank the NRC for organizing this great flawless event. Especially my special thanks goes to those who worked so hard to put together this event. Now, from now on, we will begin the panel discussion on how we integrate rehabilitation services into primary care settings. So we have panelists who also serve as speakers for today. And I'll briefly explain about the topic of today's panel discussion session. And then I will give them the opportunities to raise their comment. The overall theme for this panel discussion session is how we strengthen rehabilitation services in primary health care. So needs, priorities, and practical approaches that each country can utilize. So regarding this topic, we would like to have an in-depth panel discussion session. So the first question is how we can build effective models for providing rehabilitation services in primary healthcare. And for this, I would like to ask a question to our Japanese speaker, President Nobuhiko Haga. So what are the main barriers to integrating rehabilitation services into primary healthcare in your country? And what are the effective strategies to overcome these obstacles?
Thank you for your question. I understand that your question is about what is the barrier for integrating rehabilitation into the primary health care in Japan. The most important issue is the lack of knowledge and lack of understanding what is rehabilitation in primary health care, especially the primary care physicians, because the education on rehabilitation in medical universities has been lacking for many years. Recently, the education has developed in many of the medical universities in Japan, but the volume of the education and especially the clinical experience of rehabilitation, especially in community-based, is not so large in Japan. So the answer is the most important barrier is the lack of knowledge and lack of understanding of rehabilitation in the physical primary health care settings, I think. Okay?
예, 그러면 제가 더 그걸
Now, then what strategies or actions we can take to overcome this obstacle?
So the most important is the increase of education on rehabilitation in medical universities, but the more practical approach now is the education for the primary health care physicians. What is rehabilitation? What should they know? And also to tell them that if they are in trouble with managing persons with disabilities, they can easily contact or communicate with the physiatrists or other rehabilitation professionals related to disabled persons.
예, 답변 감사합니다.
Thank you for the answer. Now moving on, let me ask a question to Professor Kim Berkeley. The same questions. So, what are the main barriers to integrating rehabilitation services into primary health care, and what strategies we can apply?
Thank you for the question. Yes, I was reflecting on this in preparing for the panel, and I think for me the biggest issue for us is workforce. There is a real problem with having a large enough workforce and overlaps as well with the capacity and skills of the workforce. But I guess I'm in a country like Australia where we have very large distances, and reaching to rural and remote locations is a significant part of the distance in primary care. I think task sharing is one of the things that we are really exploring, and looking at how people can really work well as an interdisciplinary team to manage these workforce challenges. I, of course, have to say something about tele-rehabilitation because it's my very big interest area. I think there is a real scope for us to look at the models of service delivery that can support the workforce, as well as spread the reach of the scarce rehabilitation research resource, so that we can really reach as many people as possible with the resources that we have. But workforce is a significant issue.
예,
Thank you. Next question goes to Director Kim On-yu. So, what is the biggest obstacle in Korea, and how can we overcome that?
I believe that Korea and Japan have many shared challenges. So the lack of understanding in rehabilitation itself. So that may be the first obstacle, the biggest obstacle that we face today. And therefore, we have to make efforts to improve awareness in rehabilitation by providing various information. And also, Dr. Pauline, during her presentation, as she said, I think we really have to have a clear concept on what primary healthcare setting is. So this is for the health promotion, treatment, the prevention, and also the palliative care. So all of these are part of the primary healthcare. And for these, I think we really have to strengthen our understanding. And as strategy to overcome these obstacles, again, we have to raise the public awareness. We have to engage in various kinds of PR activities. Thank you very much. So we have representatives from Australia, Korea, and also Japan, and they are advanced nations. Now, my question goes to Dr. Pauline Klianitz, that aside from these advanced nations, for the developing countries, what are the main obstacles and what strategies we can employ to overcome them?
Thank you for the question. It's always hard to identify one or two. There's often multiple. I think workforce is possibly one of the biggest challenges in low middle income countries. So the rehabilitation workforce, particularly the therapists, physiotherapy, occupational therapy, are very limited in numbers, and they are not located. They are still even emerging in the secondary level. So in many low middle income countries, we really only have therapists established at tertiary level, and it's very hard to jump right down to primary. We have to get often some workforce at least at secondary, and then down to primary. But I also think that lack of understanding of first of all, the lack of appreciation of the large unmet need. So a lot of rehab needs are simply not recognised by others in the health workforce. So there is that lack of understanding about the need, the benefits, and certainly the urgency to bring rehab to primary care. And I will say that without financing, it can't happen. So we really have to be recognising early on that has to be addressed, that there has to be not just creation of, which is often the first step, just creation of job posts in large primary care settings, but often in financing schemes and defining benefit packages and services. So thanks.
추가로 제가
So regarding that, so Korea, Japan, and Australia, we do have some understanding, but from the central government perspective, so in order to address this lack of understanding, the lack of workforce, so the critical thing is to put monetary resources, financial resources. So in Japan or the Australia, how much financial investment is made by the government? So maybe first with the Dr. Noiko. So in other words, in order to integrate rehabilitation services into primary care, so what kind of efforts the Japanese government plays and with what amount of investment?
Sorry, I do not know the actual amount of money provided by the government in total. Sorry.
노력은 많이 하고 있나요?
Are they making efforts, the central government?
I am not working for that, but the government knows that the importance of rehabilitation, especially because Japan has become the super aged society, so the needs for rehabilitation is much increasing. However, the total budget is so limited, so it depends on the policy of the government, yes.
What about in Australia?
The same. I do not know the figures, but I can talk to you about the effort, and it is absolutely recognised and shared by the Commonwealth Government. So we have, well, 3 levels of government, but the 2 that are involved in providing healthcare, and this is a good thing that there are 2 levels of government, so the state government and the Commonwealth Government, who are providing guidance and policy and advice, but it's also a place where there can be real gaps in the system because the integration between those levels of government can be not complete and not have good coverage. It's recognised that people get better outcomes if they get primary healthcare intervention. It's also cheaper for governments to be providing these services into primary healthcare rather than in the more expensive centre-based hospital services. So there is cooperation and collaboration around that, but then there is not disagreement, but robust discussions about who is responsible for which part of the service system and who should be stepping up around this. But there has been a very large investment in Australia, not just from the health system, in the National Disability Insurance Scheme for provision of services and supports in primary care settings that has been extremely significant since 2013 was when it started, and it is now rolled out across the whole of Australia. So that has been a game changer in our country.
예, 답변 감.
Thank you for the answer. So we heard the answers from Japan, Australia, and how much effort is given by the central government, they don't know. So in Korea as well, including Ministry of Health and Welfare and local government, they are making a lot of effort. But still, people with the disabilities, they feel that the government's efforts is insufficient. I believe today's forum can once again send a signals to everyone. Early this morning, on my way to join this forum, I came from Busan City, and suddenly I thought about, I got a call from the Ministry of Health and Welfare, so I dropped by Sejong City about how to support the people with a disability for their health checkup. Not only their health checkup, but also the overall health right of the people with the disabilities. There's no strong drive or determinations and commitment by the central government. Without their support, people with the disabilities have no choice but to become a homeless people or have no choice. I strongly advocate for the people with disabilities. I have a deep concern for them. It is my strong view that Japan is much ahead of us in terms of the super age society and is making a lot of effort for the underprivileged people. We learn a lot from Japan. In case of Australia, the health and welfare system is very different than that of Korea, but still, Australian government takes a great care of the people with disabilities and also underprivileged people. They are introducing remote care systems as an exemplary country. So we need to learn from them. And there are a lot more to learn from Australia. That is why I ask you that question. So let's go to the second topic. How can links with the community rehabilitation service be strengthened in order to provide integrated patient-centered rehabilitation service? So can you share us? So first of all, Professor Bok-Soo-kyung, what and how can links with the community rehabilitation service be strengthened? Well, it's a very difficult question. So how can we strengthen the rehabilitation service? Well, as you heard, as I said, CBR can be one example, and CBR project, community-based rehabilitation service, they work together with the rehabilitation center, of course, led by the Ministry of Health and Welfare. And also there must be rehabilitation hospitals nearby. And even if you are not sick, but still, if you need a service, there must be a facility where they can visit and get some support. And also people with a disability, they need to get a job. So I believe all of the disability welfare service needs to be provided. And I guess we need to take the perspective or point of view of the people with the disabilities, not on the other side. To the same questions, I'd like to ask to Professor Kim Buckley. What is your answer?
I mentioned the National Disability Insurance Scheme in my last response, and that has been a very significant shift. And I think building on from the previous speaker, shifting to a person-centred, individualised funding approach has really made a very strong link between community-based services and the person with a disability, and then their role and choice and control in engaging services and in growing the market of services. So we now have a very large provider market of a mix of allied health professionals who support people with disability in Australia because of that policy shift from a service funded approach to an individual funding approach that is about setting an individual plan, identifying that person's needs. So I think that has really grown the links. There are still problems. There are people who are not eligible for that service, a significant number of people with disability and rehabilitation needs, and they are not eligible for that scheme. and how that is managed, and the gaps, as I mentioned before, are significant, but that has been a very significant shift for us that has really grown the links there.
Yeah, thank you very much. And what about Japan? So in order to strengthen the connection with community-based rehabilitation services to offer integrated patient-centered rehabilitation care, can you please explain Japan's example for this?
Thank you. In my presentation, I explained about the community-based integrated care system. This system was legally defined in 2014, but definitely in some rural areas, such system has been built in 1980 or 85, like that. So the establishment of the system differs among areas. So if we see the areas that this system works well, I think that there exists a very enthusiastic rehabilitation hospital or physiatrists is there. So to broaden such successful cases, so the rehabilitation staffs and physiatrists must take the leadership in the areas to build a good community rehabilitation system and integration with the primary health care.
예, 감사합니다.
Again, thank you very much. Now to Professor Sukyung-bok. So you talked about the CBR in Korea, and you mentioned that the CBR could play a role to strengthen the rehabilitation services, whereas the Australia's case, we have a very individualized funding approaches with the insurance, and Japan, it has a very strong basis for the community-based care with the leading hospitals for people with disabilities. And if there are people from the Ministry of Health and Welfare, I would like to make some requests that the funding for CBR is going to be stopped soon in Korea. So if you look at other countries that have made so much efforts to integrate the rehabilitation care into the primary cares, and CBR was actually the only result that we could rely on. But if the funding for CBR stops, then this will truly hit a strong blow to the lives of people with disabilities. So I would like to ask you to reconsider such decision. Now let me move on to the next topic. The next topic is about chronic disease management. So in order to manage chronic disease, multidisciplinary cooperation system should be established to provide effective rehabilitation services. However, the question is on how. So regarding this question, maybe Kim On-yu from the NRC can answer this question first. Okay, so the question is what approaches we can take to establish a multidisciplinary collaboration system to deliver effective rehabilitation services for managing chronic diseases. So when I got this question, the first thing that came to my mind was because I am a physician who treats the SCI patient, and we have some program in our NRC. So we have 2-night, 3-day hospitalization program where the patients can receive the checkup services for bladder. But actually, it's not limited to bladder only. Rather, it's a very comprehensive service from head to toe. So we conduct the X-ray for the injured part, and also the chest X-ray, KUB, and also we measure their in-body scan, and we also measure their bone density. And we also conduct EKG, or echocardiogram, and also we conduct various tests for the bladder, and we conduct the sonography to look at the look inside the organs. So for SCI patients, actually they suffer from various kinds of sequelae after the SCI. Also a lot of complications, and they're more exposed to the chronic diseases. That's why we do have this kind of 2-night, 3-day program for intensive health checkups. So we provide a very regular and routine health monitoring services to them. And they are recommended to receive these checkups every 2 or 3 years. So understanding the overall conditions of people with disabilities is very important, and it should be based on the inpatient data. So, and based on that, we actually established a new system called the PWD Family Doctor System. So in other words, the rehabilitatory medical institutions and the community services, they should be integrated, and also the patient information should be smoothly shared between the relevant agencies. So this is something that we have to work on. Yes, CBR is important, and as mentioned by the Chungham University professor, so based on several hospitals, we have some linkage programs, but that's not covering the entire population of the people with disabilities. That's why we have to have this kind of intensive checkup program. Now, the same question goes to Professor Pauline. So in WHO, in managing chronic diseases, what kind of multidisciplinary collaboration approaches you have?
Thank you. WHO, in the primary healthcare approaches, generally encourages that concept of enrolment of patients with a general practitioner, or what I mean is a primary care physician or a family medicine doctor. So the concept of patients being allocated, enrolled with a primary care physician. And one of the key reasons that they encourage that style approach is for chronic disease management, because you then have that ongoing relationship between your family doctor, your local doctor, in regards to your chronic disease, because chronic disease is so varied, and obviously we are talking about, you know, it could be neurological conditions, it can be cardiovascular, it can be musculoskeletal, chronic pain. And for an efficient health system, we want to avoid using specialist services and hospitals as much as we can. The less we use them, the more efficient and cheaper our health care services are. So for chronic disease management, that enrolment, that sense of working with then your family physician, and of course what you then need is that the rehab is integrated into the models of care, the financing arrangements, so that when the family care doctor recognises, and it does take them recognising when someone needs rehab, then they facilitate and trigger that, and they make sure the rehab services are wrapped into the care that someone is providing. So, you know, generally we would say that, of course, then you need the primary care physicians understanding their role, you need the multidisciplinary rehab workforce available, located, with financing arrangements that can be tapped into so that they can access it. And of course that should be wrapped up in the models of care and the care pathways for different disease condition groups. And that's really, I think, a key way forward to bring it. But it has to be quite flexible and on tap. There is such a variety, as we know, in terms of that, the needs, and we certainly need systems that are flexible.
So thank you very much. That was the efforts by WHO and what they intend to. And so we have the family doctors for the general care and doctors for people with disabilities. So they are involved in managing chronic diseases. And if there is any specialty treatment required, then they could be referred to the specialty hospitals. So if the GP system is well established in Korea, then I think maybe this could be aligned with what WHO aims for. Now, the same question goes to Professor Kim Berkeley. So in Australia's case, in order to manage chronic diseases, what kind of strategies do you use?
So we have, with our federal Medicare system, an enhanced primary care allocation for people who are recognised as having a chronic disease by their GP, their local doctor who's in primary care. But those enhanced primary care sessions are available for a range of health professionals and are allocated based on the need of individuals with chronic conditions. So increasingly we are seeing allied health professionals co-located with general practitioners and in practices with nurse practitioners as well as physiotherapists, occupational therapists, not as many speech pathologists, but occasionally that's the case. So this co-location of an interdisciplinary team has been facilitated by that funding model. But I guess in a broader perspective, I really feel that it's so important for us to step back and apply an ICF framework to people with chronic diseases so that we are really looking at function and their over time, and of course managing the health condition aspects of that, but really taking that broader view using the ICF model to really drive the way that we deliver supports to people with chronic diseases.
예, 감사합니다.
Thank you. What about Japan? What kind of approach do you take?
Yes, there are two categories, I think. One is the chronic disease in patients without disabilities, in general people. So in such cases, the primary care physicians are increasingly knowing the value of physical activity and also the value of physical therapy. And also the situation of Japan is somewhat different from other countries, that orthopedic surgeons, I think 1/3 or 1/4 of the orthopedic surgeons work for their own clinic and they do not perform surgeries. So they are responsible for caring for musculoskeletal diseases like osteoporosis or osteoarthritis. So they really know the value of the rehabilitation approach. So in such clinics, physical therapies or occupational therapies are mostly performed for patients without disabilities with chronic musculoskeletal diseases. The second category is the chronic disease in people with disabilities. In such cases, in our center, we perform a similar activity like Rehabilitation Center in Seoul. So we have the clinic for health management and health checkup for patients with disabilities. So, but our capacity is very much limited. So to generalize to the multidisciplinary approach for chronic diseases in persons with disabilities, we must collaborate with the primary health physicians thing. So recently we established a research group how persons with disabilities can go to the clinics or primary health physicians easily, or what are the barriers. We are now studying what are the problems and the obstacles and the barriers. So this will lead to the solving the problem, I think.
예, 감사합니다.
So thank you very much for the answer. So as for the chronic disease management from the perspective of physicians, I think we have already covered. But the overall community healthcare for people with disabilities, the healthcare that will be delivered by non-physicians, so including the sports for people with disabilities or rehab services. Do you have any cases? Maybe Australia, Kim Berkeley, do you have any examples for this?
So I think I just go back to the National Disability Insurance Scheme example where because it's so person-centred, there is so much more flexibility with what people choose to take up and with engagement in all sorts of activities. And again, to go back to the ICF, really focused on participation. The legislation that shapes the NDIS is grounded in the ICF and in the a rights-based approach. So people are engaging in all sorts of really interesting and diverse activities: sport, theatre, arts, employment, not as much as we would like, but that's a work in progress. So I think those activities and participation as rehabilitation is a really important part of how things are moving forward in Australia.
예, 감사합니다.
Yes, thank you very much. What about Japan's case? So aside from the physician's management or healthcare system for chronic diseases, for local community activities, for example, like the theater, sports, just like Australia, do you also have similar examples in Japan?
I understand that the systematic approach to such situation has not been performed also in Japan. The sports activities in persons with disabilities are partly supported by physiatrists, physical therapists, and so on in some areas and in selected type of sports, but the system is not systematic now.
예, 감사합니다.
Okay, thank you for the answer. So in Korea, under the Korea's health rights law, it also talks about the sports and community activities, but we are just at total phase before Japan and Australia's case. So in this regard, I believe we have a lot to learn. Of course, the system is not complete yet, but I believe that everyone engaged should work hard so that this kind of system can be well established in Korea as well. Now let's move on to the third topic. So we heard a lot about Australia, especially Dr. Kim Berkeley talked about the tele-rehabilitation and digital-based technologies, how we can utilize that for rehab services. So there is a growing interest in this topic. So when the digital technology-based rehabilitation services are expanded, what kind of changes will be brought to primary healthcare settings? So what kind of changes will be brought by the spread of the digital-based rehab services? Maybe we can talk about pros and cons. So maybe starting with Dr. Kim Berkeley. Can you answer this question?
So I did talk about this in my previous presentation, but I think that there is a lot of potential that is unrealised in this space, and that we as a rehabilitation community have a lot of thinking and reflection to do about how we integrate the things that we have already developed and experienced so far so that we make the best use of them. I think it has the capacity to transform rehabilitation, particularly in primary care, but I think in all phases of the rehabilitation journey, we can really optimise and have people working at the top of their scope of practice, and then provide support in other ways, using apps or video conferencing or telementoring, these sorts of opportunities, so that we then task share in an effective, safe, risk-managed way that has great governance. So I think it has great potential.
혹시 단점에 대해서는
What about demerits or shortcomings?
Sure. Yes, I think shortcomings during COVID particularly. So I think where it is poorly planned, where it is seen as a one-size-fits-all, so that it's not being tailored to the particular condition or context, then there can be real quality issues and safety issues and governance issues. So I guess it's the opposite of the things that I was saying are needed to make it work well. If you don't pay attention to those things, patients have a poor experience. They don't have a relationship with their provider. They don't have continuity of support and care. If it's seen as a one-off telephone call, for example, and nothing else that goes around that, that can be really problematic. So we really have to focus on the quality of telerehabilitation and pay attention to getting feedback and monitoring of outcomes for the inputs, so that we get to where we need to go.
Yes, so now the question goes to Dr. Pauline. So from the WHO, do you have anything prepared for this digital-based rehabilitation services? And I think that there are also some concerns because of these potential drawbacks. So how you can overcome that as well?
Thank you. It's interesting listening to Kim, because she's much more experienced in this than I am. But my sense is that actually, when it's done well, when it's planned, when it's co-designed with, when it's really tailored, when it's managed, implemented well, there's almost no disadvantage. It is positive. We can, impact positively in terms of the outcomes and the compliance and the dosage and just in general. So WHO's approach would be, and is one where I think we are certainly encouraging its use, but in very measured, planned ways. And from my perspective, the experience I have, and actually it involves Fiji, and we have some of the Fijian delegates here. And so in those less resource settings, I mean, it's not a, what we call a silver bullet or an easy solution. It's not that it can be quickly solve a whole lot of problems. But it can, I think, in a very focused, planned, phased, tailored way, be a positive, and there's little disadvantage. And I really recognise, though, that, and again, things that Kim has said, this is not always about going to the big technology jumps. In a lot of places, this is just we have to take, often with technology more than anything, they're really just, the change has to build on, each step has to build on it. We can't jump a whole lot of steps. So we certainly are supportive, encouraging, but want to see it done well. Yeah. Thanks.
감사합니다. 우리
So thank you very much. Now Dr. Kim On-yu from NRC. Let me ask you the question that in NRC, do you have any model for the provision of the digital-based rehab services? And have you ever experienced the difficulties, or what are the barriers? So during the COVID era, when we have to provide a diagnosis and treatments to patients, we do have experiences of remote health, but NRC doesn't really have the system for telerehabilitation. But Professor Kim Berkeley, while listening to her presentation, I actually thought about the Korea's situation, and she talked about the barriers to telerehabilitation, and many of the barriers were involved with the physicians. So physicians' concerns and resistance, and also concerns for the lack of quality. And also, we don't really have to go for high tech all the time. Low technology can also be an answer in many situations. And resistance of doctors is a key barrier. Yeah, so I also had some lingering concerns, but I thought that maybe my resistance or my concern is due to my unfamiliarity with this new technology. So while listening to her presentation, I realized that this is something that we have to adopt, and this is a kind of global trend. And so I thought that we have to come up with more strategies to overcome the situation. So now, let me ask you a question again to Dr. Kim Berkeley. That as for the telemedicine or the digital services, telerehabilitations, one of the key barriers for Korea is the potential leakage of private information. So how we can protect privacy. Do you also experience the similar issue, and how do you address that in Australia?
Yeah, privacy is an absolute top of the priority issue for us, and that's been one of the key areas that we've had to explore with platform providers, looking at encryption of data, looking at data security. We have quite strong privacy laws in Australia, and so they have guided any of the implementation of telepractice, telehealth, telerehabilitation in an Australian context. And I think that's been the same in other jurisdictions as well. I've done a bit of work in Canada. A PhD student's been working in Saudi Arabia, and I've been looking at the literature in the UK and the US. So it's a shared concern, and we have data leakages that happens, in all sorts of situations. So it's not totally fixed, but it is something that we have to be ever vigilant about. But some of it can be managed, and we saw this again during COVID, where there was platforms that were seen to be leaky or unsafe, and then the platform providers did work around increasing the encryption and security. So I think there are mechanisms that we can engage to address those very valid concerns.
예, 감사합니다.
Thank you. Well, in reality, in Korea, right next to me, we have Professor Park, and I myself and Professor Park, we carried out a pilot program targeting people with disabilities for telemedicine. One of the greatest difficulties that they have faced was their privacy. They were afraid of their privacy leakage. They were really afraid of that. And in case of Australia, the telemedicine is really well established. I believe we can learn from Australia, and it is a great lesson. Now I have a question to President Nobuhiko Haga. In Japan, digital technology-based service, do you have any actual cases in providing the digital technology-based service in the primary care? If you have any case, please let me know. And what about your future direction? If you can give us a lesson to learn, that would be great.
Thank you. Like NRC in Korea, and in a center, the telerehabilitation has not been widely used now, though some activities were performed in the COVID-19 era. So I think the one possible important issue in rehabilitation is the follow-up system of persons with disabilities, I think. Because the regular visit to our center is difficult for people with disabilities, the telemedicine or the Zoom communication may have good merit for the people with disabilities. The one is the assessment of the rehabilitation intervention, assessment of the necessity of the rehabilitation intervention, because people with disabilities have sometimes experienced decline of their physical disabilities, but it may be a little bit difficult for primary health physicians to evaluate such decline or like that, especially in cases with very complex disabilities or very rare diseases. The second one is the education of the patients and the follow-up of the home exercise by physical or occupational therapist. Because in addition to the private information issue, the other barriers is the risk management in telerehabilitation, I think. So as far as the issue of the risk management has not been solved, the more aggressive telerehabilitation may not widely accepted, I think. Thank you.
예, 감사합니다.
So thank you very much. Now my question goes to Professor Bok-Soo-kyung. As you know, the ChatGPT is emerging and the generative AI. As for the community-based rehab services, how can they be utilized?
감사합니다.
Well, in countries around the world, the biggest challenge is the human resources. They are afraid of the fact that digital technology will replace human resources, especially people with disabilities. I mean, AI can do everything from A to Z. A very simple question. Instead of doctors or healthcare workers make phone call, AI can do that. It is my view that AI can enable people with a disability to take more care of their health by asking a lot of questions. In case of Korea, there are a lot of dementia patients or people with a disability staying at home. We have Korea Telecom or neighbor platform service provider who regularly make phone calls to people with disabilities to check their health and to assess their status. So we already use AI. And instead of healthcare workers make direct phone call, just checking the safety, the status of the patients, I believe that you are saying that AI can do that job. What about you, Technical Advisor Pauline? Does the WHO recommend AI? And what is your view about the future of the AI applying to primary care?
I would say it's a little beyond. So I guess, you know, there obviously are, WHO is very much promoting the digital technologies and bringing often those guidelines and the ethical guidelines and the safety and the privacy. So I think, you know, these things are good if they're within those guidelines and practiced in a way that is safe and is obviously, I guess the risk is always when things are not constantly evaluated and reviewed, and we really just need to bring that sort of constant review to make sure that whatever the new innovations are, and the new innovations are always coming, we need to bring those similar high levels of efficacy and research and making sure it's done well. So, yeah, I would just say that. Thanks.
예, 감사합니다. 우리가
Yes, so thank you very much. We are now having a very heated discussion, and we didn't really realize how time flies by, but maybe we can have a short time to open the floor for Q&A. So do you have any questions from the floor? Maybe the panel discussion was just perfect, flawless, so that there is no question. Then can I close the panel discussion here? So far we have talked about how we can strengthen rehab services and primary care settings, and we have talked a lot with the speakers and panelists. Once again, I would like to thank all the panelists and audience. So why don't you give ourselves a round of applause to conclude this session. Thank you very much. Yes, so there was a panel discussion on how we can strengthen the rehabilitation services in primary health care. And I would like to thank the moderator and all the panelists. So why don't you give another round of applause, maybe. So, panelists and moderator, you can return to your seat.
네, 이것으로 보건복지부
So this will conclude
보건복지부 국립재활원이 주최
2024 WHO Cooperation International Forum organized by the Ministry of Health and Welfare and National Rehabilitation Center. Once again, thank you very much for your attention and time. And I sincerely hope that today's forum will be a great opportunity to come up with the effective rehab services and also provide a direction for how we can explore this issue. Once again, thank you all for your participation, for offline and online participants. Also, to ensure the continuous improvement for the forum, we prepared this survey. So please participate in the survey by scanning the QR code on the screen. Your feedback will be highly appreciated to devise the better conference next year. Thank you very much. With that, we will close.
네, 이재심